But I do like to be prompt, and according to mine, I'm a minute late, so I apologize. IT, is everything ready to go for WebEx and all of our good stuff that we know of? We're not waiting on anything there? Okay. I do know we do have a couple of members that are on their way back in. They stepped out for a quick minute. But we're going to go ahead and start with the welcome, at least, to get everybody back up to speed on the Bob Bethell Oversight Committee. I am the chair of the Senate Public Health and Welfare Committee, and because of that, I get to chair the Bob Bethell Oversight Committee this year. Next year, it will be the chair of the Health and Human Services over in the House, Brenda Landwehr, who is currently serving as vice chair. Our Senate Minority Leader and our ranking minority member is Senator Pat Petty. And then we have our staff. And if we just take a quick minute, because we have had some staff changes. Connor, if you would go ahead and start and just kind of introduce yourself to everybody so we're aware of who this new face is.
Yes, thank you. This is Connor Stengler, Kansas Legislative Research Department, and this is my finish up my first year with KLRD and my second session coming up soon.
And my name is Iraida Orr, and I am also with the Kansas Legislative Research Department. I've been through 12 sessions and have been part of the Bethell Committee for quite some time. Enjoy being here. Thank you.
Good morning. I'm Sky Westerland, the committee assistant from Legislative Administrative Services, and I will be starting my fourth session. Thank you.
Good morning. I'm Eileen Ma from the Office of Supervisor of Statutes, and I am going to be starting my 8th session here.
All right. And it looks like we do have a good crowd here with us today. Welcome. Thank you for coming in and showing your interest in this very important discussion that we're about ready to dive into. We do have some members that are present, and I think it's also good that since we're up here talking about and introducing ourselves, that you guys get the opportunity as well to introduce yourself, where you're from, and whether you're House or Senate, and why you are here. So if we could, we'll start with Representative Carpenter.
Thank you, Mr. Chair. I thought I might have more time than that. But anyway, representative from the 75th District, Northern Butler County, El Dorado, northeast of Wichita, and I chair the House Social Services Budget Committee. Thank you.
Good morning. I'm Barbara Ballard. I'm from Lawrence, Kansas, 44th District, and I'm the ranking member on Social Services. And this room I see a lot because I'm on appropriations in here as well, too. Thank you.
I'm Brenda Landwehr from the 105th District, one of many on the west side of Wichita, and chair the Health and Human Services Committee in the House, and spent many years in committees with Representative Ballard. So when we team up, just watch out. That's all we're saying. Thank you.
Hi, I'm Representative Susan Concannon. Let's see, you asked why we're here. I'm not sure why I'm here. No, I chair children and seniors, and this is my 9th year.
Good morning. Thank you, Mr. Chair. Renee Erickson, Senate District 30, East Wichita, Assistant Majority Leader and Vice Chair of Education.
Representative Megan Lynn from Olathe 49th District. I am on the Health and Human Services Committee and also Vice Chair for Social Services Budget.
Okay, thank you very much. And we do have several members attending virtually. I won't make them talk because sometimes the communication through WebEx is challenging. So doing that, we're going to move right on to our first presentation from the Office of our Medicaid Inspector General, Mr. Stephen Anderson. Mr. Anderson, welcome to the committee.
Okay, how's that? Well, again, thank you, Chairman Hildebrand. I appreciate the opportunity to be here and to discuss the Medicaid Inspector General's office with you this morning. I am Steve Anderson, and I'm going to present this update concerning our office. I want to let you know that I completed the required training and obtained the certification as a certified Inspector General from the Association of Inspector Generals on August 27th of this year. We also recently added a secretary, which brings our office to 3 full-time employees and 1 part-time employee. Excuse me. We hope to eventually recruit more staff members as appropriations allow. Since my confirmation in April of 2021, the IG's office has issued 3 reports that it identified $1.6 million in improper payments, another $1.2 million in potential savings, and over $1.5 million in lost interest. We also put out 9 recommendations for improvements in those reports, and those reports can be found on our website, and that's mentioned in our testimony. The IG's office has also referred 29 cases to the Attorney General's Medicaid Fraud and Abuse Division, 33 cases to KDHE for personal care attendant fraud. We've also made 4 referrals to the managed care organizations for potential overpayments that should be reviewed. I'm confident the IG's office will continue to produce results like these over time, and if we had additional resources, we could conduct additional reviews, audits, and investigations in a much timelier fashion. The IG's office continues to oversee complaints of fraud, waste, and abuse and illegal acts concerning the various Kansas Medicaid programs. In calendar year 2020, the IG's office screened a total of in 2019, we screened a total of 227 fraud reports, primarily from DCF. In 2020, the IG screened 650 fraud reports with 629, or 97% being submitted by DCF. That was an increase of more than 186% in 1 year. So far in calendar year 2021, the IG's office has screened 833 cases, with 736 or 88% coming from DCF. That's far ahead of 2020's pace. Since the last meeting of this committee, the IG has received 489 complaints, the majority of which allowed Medicaid eligibility fraud, and 419 were received from DCF, which was 86%. The point I want to make with that is that our number of complaints has gone up substantially that we're processing. The majority are coming from DCF. However, that percentage coming from DCF alone is going down, which indicates our efforts at outreach are reaching people, and we're getting complaints from other sources. The IG's office is currently conducting an audit of the HCBS program with the intention of answering the following questions. Does KDHE have an effective system for tracking the redetermination of Medicaid beneficiaries on the HCBS program? Are there Medicaid beneficiaries on the HCBS program that have not used it for more than 1 year? What are the requirements and responsibilities for the managed care organizations to ensure that Medicaid beneficiaries are properly enrolled in the HCBS program? We're also conducting a review of the process for Medicaid beneficiaries reporting financial windfalls, particularly windfalls with lottery and casino winnings. The review is looking at beneficiaries that win more than $10,000 from gaming and lottery and fail to report it as required. As noted in the annual report, the IG's office was working on a process improvement plan. Since my confirmation, the system's undergone a significant overhaul. We now are able to track open and closed cases more efficiently. They're closed with appropriate oversight. We can also track the types and the outcomes of the cases. Of the 3 reports that we issued, the first one was report 22-01. It was basically looked at why the KanCare clearinghouse did not have an option in its call tree for people to report fraud, which we found they did not. That has been, since the report was issued, has been corrected. If you call the KanCare clearinghouse now, you will be given the correct number to report Medicaid eligibility fraud. We also looked at the KanCare website, and it was extremely difficult to navigate, and as it was determined, there was no obvious link or website phone number given to the public to allow them to report Medicaid eligibility fraud. I have spoken with KDHE, and they are working on a plan to get that corrected, and they're aware of it, and they appreciated that we brought it to their attention. Our second report we issued was a review of Medicaid, Report 22-02. The review of the Medicaid system we looked at to determine if KDHE paid any Medicaid claims on behalf of beneficiaries who exceeded the 12-month lifetime limit. It is a totally state-funded program, so there's no federal funds involved in this. We determined that there were 912 Medicaid beneficiaries that had 13 or more months of eligibility during our review period from January 2018 to April 2021. Because the individuals were not taken off of Medicaid eligibility after the limit, it resulted in state funds being used to pay Medicaid claims for ineligible persons totaling over $1.6 million. Vice Chair Landwehr, you had previously asked about the 12-month limit, and we did some research on that. It's in the report, but it seems in 2009, Governor Parkinson dropped it from, it had been dropped from 24 months to 18 months, then the governor dropped it from the 18 months down to the 12-month limit that it exists now, and that was in 2009. As a result of our review, the KDHE staff began the process of removing 556 individuals who are no longer eligible for Medicaid. We estimate a savings of over $1.2 million as a result of them taking that action. The third report we issued involved the review of capitation payments, 2203. I want to let you know that that report was issued on August the 5th. However, on September the 17th, we amended that report. It's available on our website, and it was not a significant amendment, but we removed Maximus's name from the report. And so I did want to bring that to the committee's attention. That report was amended. In that report, we found that capitation payments were made after beneficiaries' deaths. It had been previously reported that there were 25 individuals who had died and they were not reported, or that the system knew about it, but they didn't take any action, and $1.3 million was made out in payments. We also conducted a 2-year look back from July 19 to July 2021 of capitation payments made on behalf of deceased beneficiaries. We found there were 632 cases where that had occurred. The capitation payments totaling over $19 million were eventually recouped by KDHE via offsets from each MCO. There were 56 cases within this group where capitation payments continued for 5 or more years at the beneficiary's month of death. We looked at the time of these overpayments that were in possession of the MCOs and conducted a cost of money analysis and determined that the cost of money to the state of Kansas was over $1.5 million. COVID-19 monitoring. We continue to look at the COVID-19 pandemic to see if there are situations where evidence of improper billing for COVID-19 testing. To date, we have not found anything significant, but we continue to look. That concludes my testimony. I'd be more than happy to stand for questions.
Stephen, thank you for your testimony, and we do have a question from Vice Chair Landwehr, Representative Landwehr.
Thank you, Mr. Chairman. And I think I'm just a little bit confused on the capitation, capitation payments on item 2 down there is, okay, there's the 19 million and then there's a 1.5 cash loan.
Yes.
What's the loan for?
We looked at what the MCOs basically had the cash of over $19 million for an extended period of time. So we looked at what the cost of that money was to the state of Kansas, because that money could have been in the state treasury or being used for other resources, but instead it was in the profit margin for the MCOs. So we looked at what the cost was, and we took basically the prime rate and stretched it over the period that the money was to them and considered that to be lost interest for the state of Kansas.
Okay, yeah, just the word loan is what was throwing me, and I think if it had been explained that it was interest that we would have received would have been maybe a better explanation.
I appreciate the feedback. Thank you.
Stephen, I do have a question or two for you. The first question is, there was a recent federal report that just came out, found similar findings, but their number was 10 times higher than what yours was. Do we know what the difference in their inspection report versus your inspection report?
Yes, they had a different review period than ours. They also took a different methodology in that we looked at individuals who had been identified as deceased, but the recoupment had not been made. Whereas HHS OIG's report looked at Social Security data and actually found a substantial number of people that KDHE didn't know about as being deceased, and that's what their numbers are based upon.
Stephen, thank you. And that probably brings questions more for our Sarah Fertig when she comes up about how they responded and how their system would catch that Social Security numbers. Do we have any further questions for Stephen? Stephen, it doesn't look like we do. So again, thank you very much for your testimony.
Well, thank you. I'm grateful for the opportunity.
Okay. Committee, next we are going to hear responses from state agencies and our MCOs on unresolved issues. But first, Connor is going to give a presentation on the spreadsheet. Connor?
Thank you, Chairperson Hildebrand. This is Connor Stengler from Kansas Legislative Research Department. I am going to let each party go through the spreadsheet on their own. The committee members, have the physical copy of the spreadsheet right there in front of you, and it's also being cast to WebEx, if that's okay with you.
Yeah. Connor, thank you very much, and thank you, Madam Vice Chair. She reminded me that we do have some new members that probably have not seen this before. The spreadsheet, and Connor will probably explain it a lot better than I will, but this is all the unresolved issues that have come up in the past, and whether it deals with their MCOs or our agencies, and the responses, whether or not they have been completed or they're still in process, and what they're doing to fix these issues. So, Connor, thank you very much. So our first one is Sarah Fertig, Medicaid Director for Kansas Department of Health and Environment. Sarah is with us virtually. Sarah, welcome to the committee.
Thank you, Mr. Chairman, and good morning, committee. The first item for KDHE's response is item number 19. On my printout, that is on page 27. However, I will let staff get to where we're talking about. And there we go. Thank you. Right where we were. So this particular item, we had some conferees talk about the need for a rate increase for private duty nursing services for individuals who are on the technology assisted waiver. These are kiddos with complex medical needs, and they often require round-the-clock private duty nursing. The rate for Medicaid for a long time was quite low, less than $32 an hour. And so a lot of families had difficulty recruiting staff that they needed to take care of their kiddos and meet those healthcare needs. So there were advocates last session who lobbied for a rate increase. And I must request your forgiveness, Mr. Chairman. There was actually a typo in our response. The advocate said...
I apologize. I've got a Representative Vice Chair Landwehr has a question.
Of course.
Actually, a comment, Sarah, is because our staff understood that some of us are a little older and we like bigger print. Our hard copy sitting in front of us, for those of you who are trying to follow that are new, is page 24, is where number 19 starts.
So, committee, for those trying to follow along with there's two different versions. There's the ones that have the enlarged imprint or print. That is the one that Representative Landwehr was referring to. And those with the regular print is on page 27. So, and I'm kind of a regular guy, I guess, so. And just for the record, Representative Landwehr has the big print.
Well, I hope I have it over here too.
Sarah, thank you for letting us go down that rabbit hole. And if you want to continue, thank you.
Of course, Mr. Chairman. I'm not going to comment on that. So anyway, just for some context on this particular item, there was a lot of discussion last session on the need to increase the Medicaid rate for this particular code. And we were thrilled to see that the legislature agreed. And so there's a typo in our response. The hourly rate was actually increased to $43 an hour, up from about $31.25. So that is a significant increase, and we were thrilled to see that happen. Both KDHE and KDADS supported that increase. So, Mr. Chairman, because it seems that some action was taken on that item, KDHE would respectfully request that that item be considered closed.
Sarah, thank you. And committee, the way I have done this in the past and will continue it whenever either an MCO or an agency requests for that to be open or closed, we will do that without objections. If there's an objection to it being removed, we will then keep it. So without objection, that will be removed as an action item. Okay. Seeing no objections, that's removed. Thank you, Sarah.
Thank you, Mr. Chairman. The next item for KDHE's response is item number 23, which is on page 29 of my handout. There it is on our screen. And this was a remark that was made in February of 2020. There was a concern from the conferee that the state might decide to pursue a Medicaid block grant model under an 1115 waiver. There has been no discussion on doing that. That is not in any of the plans that we've discussed with the state. So I would respectfully request that this item be closed as well, because there are no plans to go that route.
Committee, without objection, action item number 23 would be removed. Seeing no objections, item number 23 will be removed. Thank you, Sarah.
Thank you, Mr. Chairman. The next item for KDHE is on page 35, item 29. And this particular item relates to a specific dental code. Oral Health Kansas had asked for Medicaid to increase the rate for that code. We did some analysis following the last Bethell committee to see if that's something that we could accommodate within existing appropriations. And we think we can. It's a fairly minor impact. So we'll be discussing that in caseloads in the coming months. And so we're planning to increase that rate effective January 1st, 2022. And Mr. Chairman, if there's any questions, I'd be happy to answer them. Otherwise, I can move on to item number 30.
Sarah, I do not see any questions from anybody on the committee. So if you, oops, we do have one from Representative Ballard. Representative Ballard.
Thank you, Mr. Chairman. All right, so with 29, you say that this will be effective January 22, but this is for hospital calls, or the code would increase dentist ability to provide sedative dentistry. Would you just explain that further, please?
Sure. In some instances, it's challenging for a dentist to provide sedation dentistry, and it's commonly used with, for perhaps individuals with disabilities who might have difficulty sitting through a dental procedure in the absence of sedation. And it's difficult for dentists to maintain sedation capabilities within their own office. It's just very costly. And there's a specific type of license or endorsement required in order to do that. So there's a fee that's assigned when that we pay when a dentist instead performs that service in a hospital, so that they can access the sedation services and the infrastructure and the equipment and all of that. inside the hospital. And previously, the rate was quite low, and that made it challenging for Medicaid beneficiaries to try and find dentists willing to do that service because the compensation was so low for that. So we did our own analysis, and we agreed with Oral Health Kansas, and so we decided that we would pursue a modest rate increase there.
All right, that explains it. Do we have any idea what that increase might be?
Oh, I don't recall exactly where we're going from and to, but the overall net effect, I think, was under $200,000 for an entire year, which in Medicaid money is very, very minimal.
Mm-hmm.
And about
Very nice.
65% of that is paid by federal dollars.
Thank you. I appreciate the explanation. Thank you, Mr. Chairman.
Okay.
Sarah, I see no further questions, so thank you.
All right, thank you. Moving on to item number 30. So this particular item is part of an ongoing discussion that the state has had with the CMHCs on a particular code that would allow CMHCs and mental health providers to bill for a service called family therapy without the patient present. This is a service that can happen when, for instance, you have a kiddo in foster care and the provider provides therapy for the kiddo, and then they want to speak with the foster parents alone and talk about things that can be done in the household, structure, rules, things like that, that can help improve the kiddo's behaviors. This is a code that we've been looking at providing for some time. We've received conflicting information from CMS as to what would be required from the state in terms of oversight, in terms of state plan amendment language. Those discussions kind of were put on pause over the last several months as we focused on launching the CCBHC project, but we've reached out to CMS again and we're resuming that study. So, we're also considering how the CCBHC model will impact how that code is paid and how that will affect our fiscal impact estimates. So that's part of an ongoing discussion, Mr. Chairman, and we continue to talk with the CMHCs about this item all the time. I'd be happy to answer any questions on that particular item.
Sarah, thank you. We do have a question from Representative Landwehr.
Mm-hmm.
So, Sarah, we're not paying an enhanced rate at this time, or we are?
You mean the CCBHC rate, Representative?
Yes.
No, not currently. That goes live on May 1st, 2022.
Okay, when you go into that, because we've got one CMHC that is in their second year in a CCBHC, and then we'll have, I want to say 5 or a total of 6 that come online this year. So they'll all get the this enhanced rate in May 1 of 22, correct?
That is our target date, yes. That's what we're working towards.
Okay, you just said that's your target date. Why would we
Yes,
not?
I mean, that's it.
Why would we not
that's
meet
our
that?
goal.
Why would we not meet it?
We fully intend to meet that, Representative. In fact, and as part of my update later on, we'll talk a little bit about, kind of the aggressive timeline that we have. We've been meeting with the CMHCs weekly since July. And so we have a really good timeline to get that done. And so we have no reason to think we won't hit May 1st.
All right, thank you, Sarah.
Mm-hmm. The next item, Mr. Chairman, for us is item number 31, which is right below item 30. And the Disability Rights Center requested that COVID-19 cluster data be reported in a particular fashion. Starting in September of 2020, KDHE started reporting clusters in facilities, including long-term care facilities. So KDHE would ask that this item be closed because it appears that the conferee's concern has been addressed.
Committee, without objection, item number 31 will be removed. Seeing no objections, action item number 31 is removed. Thank you, Sarah.
Thank you, Mr. Chairman. Let's see, the next item for KDHE is item number 33, which is on the following page, I believe. And Mr. Chairman, this is another item that we think is kind of obsolete at this point. The conferee's concern was access to vaccines through the nursing home pharmacy program. And at this point, anyone who wishes to receive a COVID-19 vaccine can get one. So we would request that this particular item be closed as well.
Committee, without any objections, action item number 33 will be removed. Okay, we have a Representative Landwehr.
So Sarah, we are assured then that the local health departments will be able to perhaps come to the facilities, et cetera, to provide that if needed in the future?
Representative, I would defer to Dr. Norman on how that interaction goes with local health facilities, but I can't speak to any rules that an individual nursing facility may have in terms of who is allowed to come inside the facility. I can't really speak to that, but in terms of access to vaccines, that is for anyone who wishes to have a vaccine.
Okay, because I think as I'm reading this from the concern from Leading Age is that they wouldn't have ensuring that the adult care homes and their staff would always receive the priority. So I think that's the question. So I guess when Secretary Norman speaks to us, we can come back and get clarification, Mr. Chairman.
Senator Erickson.
Thank you, Mr. Chair. Does this also include the boosters?
Senator, I don't believe this particular item did. This dates to February of 2021. That's when the conferee spoke. And at that time, we were restricted on who was eligible for the vaccine. There were priority groups who got first access to the vaccine and those who got later access to the vaccine. So I think that's the context of where this conferee's comment was. Back in February, I don't think there was even a whisper of booster shots at that point. So I don't think the conferee's concern went that far.
Thank you, Sarah. Thank you, Mr. Chair.
Committee members, we did have questions. Was that your objections to having this removed at this time, or are you? No, okay. So, Sarah, we are going to wait and talk to Dr. Norman before we will remove this. Action item number 33. Thank you.
Certainly. And the final item for KDHE's response is item number 39, which happens to be on page 39 of the handout. And there were a number of conferees last session that sought approval to increase the protected income limit for HCBS and PACE participants to 300% of SSI. And we were thrilled to see that the legislature agreed, and there was legislation passed to allow that to happen. And KDHE is thrilled to report that CMS has approved all of our waiver amendments and basically the administrative work that we needed to do to receive formal CMS approval to make that increase effective July 1. So everyone whose case was affected by this protected income level change has already been notified and it's already operationalized. And Mr. Chairman, I think that concludes KDHE's updates.
Sarah, thank you very much. And that was a request to remove action item 39, was it not, since it's already been accomplished through legislative?
Yes,
Okay.
I would say so, Mr. Chairman.
Okay. Committee, do we have any objections to removing action item number 39? Seeing none, that is removed. Sarah, thank you very much for your update on the action items. Committee, do we have any last questions for Sarah before she goes? Representative Carpenter.
Thank you, Mr. Chair. Sarah, have you figured out how all of this affects our budget neutrality?
I'm so glad you asked that, Representative Carpenter. I know that's an issue that you care about. Luckily, increasing the protected income limit has no effect whatsoever on budget neutrality. I confirmed that multiple times with our actuaries, so that increase did absolutely nothing to affect our budget neutrality. The rate increase that was provided to the TA waiver private duty nursing rate. That does affect our budget neutrality, but it's something that we're monitoring consistently. We have discussions about, pardon me, our current budget neutrality status on a weekly basis with our actuary, so we're monitoring that quite closely.
Sarah, and that jars a question for me. I believe during our last Bob Bethell committee, we heard where there was a discrepancy. The CMS said our budget neutrality was something different than what we had, or you guys had calculated. Did that ever get resolved, or are we still trying to find out what the accurate numbers are there?
Thank you, Mr. Chairman. So that particular discrepancy did get resolved. Unfortunately, the way CMS resolved it did not really add much cushion to the state's 1115 budget neutrality waiver. And as part of the work that we've been doing in the last several months, we've been reviewing those calculations to see if there were any other errors made. We believe there were. And so one of the things we're working on is a proposal to CMS that would correct some of those technical errors that we feel were made in the budget neutrality calculation. So yes, the earlier error has been corrected, but not in a way that was terribly helpful to the state. And so we're seeking approval for CMS to correct other errors that we found in the meantime.
Sarah, thank you for that update. Committee, do we have any further questions for Sarah on the action items? Not seeing any. Sarah, thank you again. We will now move to our next conferee, Janice DeBoer, Deputy Secretary of Programs for Kansas Department for Aging and Disability Services. Oops, Sarah, I apologize. I did not see Representative Ballard's hand. She does have a question if you are still there, if you wouldn't mind.
Of course.
Okay, sorry about that.
Thank you, Mr. Chairman.
Representative
No,
Ballard.
you didn't see my hand because I was late. I apologize. But in reading 39, I just need an explanation. We talk about FMAP increase of 10% that is part of American Rescue Plan should be used for services and programs that would directly impact rather than benefit the providers. I understand that part, but these funds are, of course, one-time funds and are to supplement, not supplant the level of state funds. Would you explain when we say one-time funds? Because when I think of one-time funds, it says that I'm going to get it this year, but I may not get it the next year. Or am I reading that incorrectly?
No, Representative Ballard, you are not. And I'm happy to clarify that. And I believe both KDHE and KDADS will be talking more about this 10% FMAP increase in our agency updates later on in the day. But the American Rescue Plan Act includes a provision that would allow states to draw down 10% extra federal matching funds for HCBS, PACE, and home health programs over the course of a 12-month period. And then we could spend that money over the course of, I think, 3 or 4 years. So it's a one-time influx of money that we can draw down. And one of the conferees had suggested that we allocate some of that money to increase the protected income limit. However, the legislature's already taken care of that, so we don't need to do that anymore. But the conferee is correct that that 10% FMAP bump, as Janice DeBoer calls it, the 10% FMAP bump, that is a one-time influx of money. And so we have to be mindful about using that for ongoing expenses into the future because we'll only have it for a shortened period of time. But both KDHE and KDADS will go into that a little bit more this afternoon.
Okay. Thank you for the explanation, and thank you, Mr. Chairman. That was a little bit alarming when I read that. Thanks.
Janice, thank you very much for waiting, and Sarah, thank you very much for that explanation, and that removed any objection to removing or closing action item 39. So without any further objection, action item 39 will be closed. And Janice, welcome to the committee, and thank you.
Good morning. Thanks, Connor. Okay, my name is Janice DeBoer, Deputy Secretary of Programs with KDADS, and I am pleased to be here today. And also, I will note that Several of us are just around the corner, and I may need Scott Bruner to help me on a couple of these, but he'll be up this afternoon also. So just a heads up, we're just around the corner. So I will start on page 1 of the KDADS section of this 41-page document. So start on page 1 with me, which is past page 5. So there's a second page 1. Does everybody find it okay? So I'm not going to talk about the MCO issue, so skip past the MCO pages, go past page number 5, and then there's a second page number 1. Okay? Which is oh gosh, Connor, did I get that wrong? It's page number 1. It's actually page number 1. It's just the second page number 1. I think we're okay. Yeah, I think it should. Yes, the IDD waiting list is where I'm going to start. Okay? Yep. Yep. Well, we thank your team for helping us keep this straight, so.
Janice, is that large print number 1 or regular print number 1?
Senator, I will confess, last night I lost sleep because I printed out small print deck of 41 pages, and then I got here this morning and said, Connor, do you have a copy for me? It turns out they're exactly the same. I'm like, oh my God. So I will refer to my small print because I've made notes. But anyway, I think we're good to go. So we'll start with the IDD waiting list. And I am going to share with you right up front, I need for you to flip over to page number 3 because there are that many conferees' comments about the waiting list. So Connor, I'm with you. I'm tracking with you now on where we were going to start, which is actually on page number 3. I apologize. Okay. Oh my God. 1, 2, 3 are all the same issues. So we've got page after page after page about waiting lists for IDD and the PD waivers. So here we go. The good news is Sarah referred to the 10% FMAP bump. And we are pleased to report that we did include dollars in our request to CMS as part of our 12 projects to bring in an expert to help us analyze these waiting lists, help us get a better feel for who are these individuals waiting, what services do they need. So we did include a request in our submission. We do expect that to be approved. We already have a scope of work. So Commissioner Amy Penrod and her team are already crafting a scope of work. The minute we get approval, we will get an RFP on the street to bring someone in to help us determine who are these people waiting, what services do they need. So with that said, I'm going to add some context to this 10% FMAP bump because you're going to hear me say a couple of times throughout this presentation that we've made that request as part of our bump, our 10% FMAP bump. So there are 3 buckets, and Representative Carpenter, we sent you a copy of what we submitted to CMS. There are 3 buckets in our request for this 10% money that we can now spend because of this increase in the FMAP. The first bucket is workforce, the second is employment, the third is access to care. So this particular item fits within that access to care, and we do intend to spend money figuring out what's going on with the waiting list. So I'm going to move on unless there are any questions.
Representative Landwehr.
Okay, Janice, and perhaps I'm just a little bit confused. We had in April, you were meeting with the stakeholders to design a study, but as of today, we're still developing the scope of that study to decide to determine what to do on the waiting list, so 5 months?
Well, we'll write the scope for an RFP. I mean, we met with stakeholders to get their input as far as what would a scope of work look like. But we're hoping that as soon as we get approval, we've been waiting for CMS longer than we expected. We submitted our plan on July 9th. We thought we would hear something on August 9th. And today's September 22nd, and we still haven't received any questions from CMS or approval yet. So
what is the cost of the study? Because if I understand this correctly, what I'm reading is that this 10% FMAP bump is going to pay for the cost of the study, nothing for the workforce, employment, or access to care. Is that correct?
Right.
So what's the cost of the study?
I think Amy has it in her detail. I think it's $2 million, but I might be getting that mixed up with another $2 million. So we can confirm with Amy. It is about 80 to 84 million is what we expect to receive with the 10% FMAP bump. So we've got 12 projects that fall within these 3 buckets, and this is one of the projects.
Okay, so will we hear, as we proceed through all of this, what those other projects are?
All of the projects didn't fall under this particular report, but they will this afternoon. So this afternoon, we will share all 12 projects with you.
Thank you.
Janice, thank you. And something sparked hands going up. So we have a question from Representative Carpenter.
Well, it's more of a statement than last year our committee, and it passed through the appropriations process. We had a proviso that provided for a study that will have a 2-day meeting the 21st and 22nd of October, studying the ID wait list. And so we're not interested in waiting for somebody else to tell us that. We need to get on that. So we will have a study, do a deep dive into the wait list. Many of the questions that we have all had, you know, how many people are waiting for services? How many people have just signed up because it takes 9 or 10 years to get services? Can we do different waivers, you know, versus all 6 services that the waiver now provides? If we could do a 2-service waiver or 3-service waiver and amend our 1115 waiver. So we will be looking at that in depth on the 21st and 22nd of October. Thank you.
Janice, seeing no further questions, you may proceed.
Okay, on number 2, this was from April of 2019 that Matt Fletcher asked for us to explore a better model for managed care under KanCare. From our vantage point, the new version of KanCare is on the horizon. We will work closely with KDHE and others as a KanCare procurement, during the KanCare procurement process. So from our vantage point, we would request that this item be removed as KanCare is being renewed.
That's action item number 2, page 3 on our handout. Okay. Committee, do we have any objections to removing that action item number 2 for KDADS? Not seeing any. That action item number 2 will be removed. Janice?
Thank you. Number 3 is from Cindy Luxem back in April of 2019. She requested that the nursing facility reimbursement payments be in accordance with the statutory formula for 3 years of actual costs. Our update is you all did approve a 3% increase in nursing facility funding in the 2021, during the 2021 legislature, and we did obviously implement that directive. So we would also ask that this be removed.
Representative Landwehr.
Thank you, Mr. Chairman. So, okay, I understand the 3% increase in the facility funding. But my question goes back to, are we now then in compliance with our statutory, which is that 3-year average? There's a word for it, and I can't think of it off the top of my head.
For rebasing?
Rebasing.
Yeah.
So does this put us in compliance with rebasing in statute?
We did use the 3 years as a base year, yes. The 3%, Representative Landwehr, I would need to go back to see if we were 100% with your 3% appropriation. I'll need to go back and check, but we did use 3 years for the rebasing, yes.
Representative Landwehr, does that alleviate any of your concerns on removing action item number 3, or?
No,
we'll
I
leave that
don't
there?
think so. And actually, I've got a couple of members of the Social Services Budget Committee that I think that are kind of in agreement with me. So I'd like to leave this item open, and if you could come back to us, Janice, and show us those numbers, because I'm not sure what I'm seeing and what you're saying are matching up. So we'll figure out where, perhaps I've made an error on that.
Okay, okay,
Thank
we
you.
can do that. Item number 4, which is page 5, this came from Mitzi in November of 2019. We appreciate the combined item. This was use of antipsychotic drugs, and she was also concerned about chemical restraints in other adult care homes, including assisted living home plus or residential care facilities. We don't have, as we reported in June, we don't have the statutory authority to require adult care homes that are only state licensed to report the information. We continue to conduct surveys, however, and Scott Bruner reports on antipsychotic use in nursing facilities in front of this committee every time we meet. So we would ask that this be removed, but it's also something we report on. You ask us to report on at every KanCare meeting, so it is ongoing.
Yes, committee, that is action item number 4 on page 5. Representative Ballard.
Thank you, Mr. Chairman. I think because it's ongoing, you're not asking to remove it, or are you?
Well, that's completely, I would ask to remove it because we report on it every quarter, or every time you meet, you ask us to report on this, and Scott reports on it separately, but it can stay.
Okay. Mr. Chairman, I would ask that it stay, and part of it is because this continues to be a problem. And as to what degree of problem it is, I'm not sure, but because it does continue, and because we have such transit staff, and people come in and out, I don't know what the training level might be that's going to be eliminate that. So for that reason, I think we should get that report, because I think it really is a concern in these facilities.
Representative, and I agree with the line of thinking that it's something that we would not forget as a committee to hold accountable. So we will keep action item number 4 open. Representative Concanon.
Thank you, Mr. Chairman. Just to add on to that, the Senior Care Task Force is also looking at this issue, and it will be in one of our working groups. And we just had a report on that a week or 2 ago. So being talked about on a couple committees. Thank you.
Representative Landwehr.
Thank you, Mr. Chairman. I'm thinking, Janice, as I go back through this and I look at the KDADS response, and there's been a few times that you've asked for, that this could probably be closed, and then you're talking about in June of last year how this could be consolidated with monitoring other antipsychotic drugs. I think probably at some point it might be good for this committee to actually see what report you're referring to.
Okay. Yeah, and Scott will have it this afternoon
Okay.
in his presentation. Yeah.
All right, thank you.
Yep.
Seeing no further questions, Janice, you may proceed.
Number 6, item 6 is, this again was from August of 2019, and Roxanne was concerned about dual diagnosis, individuals who were on the SED waiver and were moving away from IDD waiver. And I will just share with you up front, This is one of those items that probably we've not responded to as quickly as we could have, and now we find ourselves in a new opportunity that the SED waiver is up for renewal in 2022, and that will require us to work closely with stakeholders. So we will make sure that this particular item of Roxanne is included in that conversation as we renew the SED waiver.
Senator Gossage, then Representative Landwehr.
That's KDHE, not KDADS.
Representative Landwehr.
I apologize for that, Mr. Chairman.
That's okay. I was sleeping when she raised her hand, so.
I doubt if you were, you're too sharp for that. Okay, so have we addressed the issue? Okay, I understand the renewal is up, but have we addressed the issue of the dual diagnosis getting dropped?
Well, she wants an individual child to transition from the SED waiver to the IDD waiver automatically. So
are we automatically transitioning them to the IDD? We still are not today.
no.
So the renewal of the SED doesn't change anything next year, so we haven't addressed this issue. Would that be correct?
Well, we will address it as we renew the SED waiver. This will be a conversation we have with stakeholders as we renew the SED waiver, that we'll have an opportunity to receive comments and work with stakeholders as to whether there is support for an SED child to automatically transition to the IDD waiver, which has a waiting list. So whether, that'll be the conversation we'll have with stakeholders and get their input.
Okay, and Janice, here's where the frustration comes in, and I can't speak for a couple of other members on this committee, but the first comment of this was brought to our attention in August of 19. The first response from KDADS was November of 19, and we're still sitting in the same position that we were in November of 19 with no resolution. So how do I know that you're going to resolve it between now and next year?
Well, Representative Landwehr, I hear you, and I acknowledge that this is one of those items that you all have asked us to continue to monitor and continue to review. Initially, we indicated that we simply don't support this approach. We don't support the idea that SED kids transition to the IDD and take priority over IDD children who have been waiting for years. So, we indicated initially we didn't support this policy. You asked us to continue to work with stakeholders and keep this on the table anyway, and we have done that. What we haven't done is pull stakeholders together to get some additional input as to whether or not that is a direction that we should go, and then bring that information back to you. That's what we haven't yet done, and the SED waiver renewal will require us to do that. So yes, we have been slow in responding to this individual conferee's request that SED children automatically transfer to the IDD.
Well, and I can appreciate wanting to have, to do due diligence on that because of the issue with the waiting list.
Right.
But to hear that, we're going to wait until our SED is up for renewal. This is the stuff, Janice, that as legislators, it frustrates us that it takes our agency so long to respond. And now you're just telling me, well, now we're going to bring that up in our discussion for the next year. That discussion could have already been done. A determination could have already been done. And then the discussion then has to come back to the legislature of what are we willing to put up financially if there's a cost to this. And we're not there yet. And this started in August of 19. We know it was long before that, but that's when it got brought to our attention on this report.
Right.
And that's what makes this spreadsheet so important. And you and I know, you and I go back a lot of years, and I know your experience, I know your knowledge, and I know your ability, and I get frustrated with delay answers. And I apparently am not coming across clearly with that, or perhaps you guys don't care that I get frustrated with the answers from KDADS. Because I know what you're capable of, Janice, I really do.
Yeah,
You're
and-
very good in these areas.
Yeah, and I wouldn't say, Representative Landwehr, from my vantage point, this hasn't been a question of why we haven't done it. I'll share with you resources. I mean, resources are limited. We've had other priorities, and we haven't brought stakeholders in to specifically address this issue. We haven't gotten that done yet. It is on this chart. We know it's on this chart. We know it's something we need to do. We just simply haven't gotten it done yet, and now we will. And that's just a resource issue. That's nothing more than just resources and priorities and COVID and shifting and the ground shifting, and it's just resources. That's just all it is. I think I'll just speak for myself as Deputy Secretary of the agency, and the Secretary will be testifying later. I think we've worked really hard over the last few years to deal with some unexpected priorities that we didn't see coming. I think we've done a great job. So I will say on behalf of my team, and even myself, that yes, we are very capable, and yes, we have worked really, really hard these last few years and done the best we can with the resources we have available, Representative, with all due respect.
Well, and in June of '20, KDADS requested that this item be closed and removed.
Right.
So I start getting the feeling that there is no intention of KDADS really taking a serious look at this issue.
Well, and you ask us not to. You ask us not to remove it, and we did not remove it, and we will address it. You ask us not to remove it, so we indicated that we don't support this approach, but you ask us not to take that position and to reconsider, and we will. It's just taking us a while to get this on the table and have this conversation, and we need to have it with Roxanne in the room and with others in the room, and have a conversation. Do SED children take priority over IDD children who have been waiting for years? I don't think that's an easy answer. So maybe, Representative Landwehr, I'm taking this too seriously. Maybe I think this conversation is going to be tough enough that we've got to have other people at the table to help us make that decision. Does an SED child take priority over an IDD child who's been waiting for years? I don't think that's an easy answer.
Well, and I would agree it's not an easy answer.
Right.
And it's not a new question that we've
Right.
had before us.
Exactly.
But we also know that so many times in the social services realm that it takes a second seat to a whole lot of other things in our budget. And I can go back to, 1997, my first stint on social services budget, and that's when Representative Ballard started too. And I don't think the questions are any different today than what they were then. So we have to get to the hard questions to really know what we're funding. So I appreciate that, and I appreciate you're always willing to have these discussions, because you and I both know it's not personal, it's just about getting to the issues.
Right.
Thank you, Janice.
Yep.
Janice, thank you. We do have another question from Senator Gossage, but before we go to her question, because we do have so many new members on the committee, acronyms sometimes get thrown out with little explanation to those that aren't aware of what they are. And it's really kind of an important issue, and you raised some very good points about why you do not support it. Explain to those listening online that are not aware of the acronyms and those on the committee that are new, what is IDD, why they're on that waiting list, and what is the SED, and what that would mean, and what would result if they were then prioritized over someone currently on the IDD waiting list. And then after you do that, we'll go to the question from Senator Gossage.
Okay, I'll be happy to do that. So thank you, Senator. The SED waiver is for severe and emotionally disturbed children. And oftentimes, those children do have behavior issues. I mean, we are talking about severe and emotionally disturbed children. And they do have dual diagnosis, and they do have behavior issues. And we have a waiver for them now, and there is not a waiting list. So the CMHCs help us administer that waiver, and they do a very nice job. And I'll be honest with you, KDHE, we work closely with them, that if we have a severe and emotionally disturbed child who needs help and they go into that CMHC, we've accelerated the eligibility process. We get that child into services as quickly as we can. And then the SED waiver typically is not typically considered to be a long-term stay, if you will. Children don't stay on this waiver for a long amount of time. It works very well. I think, Senator, there, and Amy can correct me, I think we've got over 3,000 children that tap into this SED waiver every year. It might even be closer to 3,500. But, so these are severely and emotionally disturbed children who need help, and they need help now. And that's what this waiver does for them. The IDD waiver, which is for the intellectual and developmentally disabled children, as a general rule, that move into adulthood, that is a long-term waiver. You're diagnosed sometimes from birth, diagnosed throughout life, and you come onto the IDD waiver and you stay honestly for years. But the reality is we've got a waiting list for those particular HCBS waiver services. Now those, what I will call IDD children, those individuals do get a medical card. So they do get on KanCare. But they may wait for years to actually receive waiver services which help with with activities of daily living, help with residential services, with daycare services, so that the waiver, the IDD waiver, is I'm not going to say lifelong, but it can be a lifelong waiver service that you stay for years. So we've got people, we've got kids who have been waiting to receive those services for years. So this proposal is that SED child who has a behavioral issue that needs to be addressed right now, which we address right now with the SED waiver, that those children should transition automatically onto the IDD waiver if needed and stay for a lifetime, which means they take priority over the other IDD children who have been waiting sometimes for years. That's the complexity of this tough conversation. Now, whether can we deal with it and address it and speak to it? And I'll be honest with you, the secretary could probably articulate this better than I, and so could Amy Penrod. But could we develop some type of criteria for the SED child that if you meet this particular criteria, you can transition? Yes, and those are the conversations we have yet to have as to whether or not an SED child should take priority over other folks children who've been waiting for years. So, Senator, I don't know if that helped at all, but I hope it did.
Yeah. That is what I wanted the rest of the committee and those listening online to understand. It's not that the SED waivers don't, once they qualify for IDD, it's putting them at the front of the line. Correct. Is what action item number 5 is. And me personally, I was not involved with the Bob Bethell committee when this got put on as an action item, and I would probably duplicate your concern whenever we're going to prioritize one group over another group, that they both need services. It's very important for both groups to have that service, to prioritize one as a priority over some that have been waiting sometimes up to 9 years, we've heard, is very difficult and probably should not be rushed to any type of rash judgments. So I would like, though, for you guys to proceed and make sure we do get the ball rolling, because the communication probably has been taking too long to come up with a solution, or hey, this is not a solution that we can proceed with. So I would share the same frustration as Vice Chair Landwehr, that the timing of coming up to a resolution is frustrating, but I wanted everybody to understand what that issue was. It is very complex, and we do have some serious things to consider before we rush into doing that. But we do need to come to a resolution soon. Senator Gossage.
Thank you, Mr. Chair. I appreciate you doing that, because actually that was part of my question, was clarifying those. It seems to me that if someone is on the SED waiver, they may not.
Senator Gossage, can you turn your mic on so, oh, okay, sorry. That way people online can hear what your question, if you wouldn't mind starting over.
Not at all. Okay, can you hear me now? Again, Mr. Chair, I just wanted to say thank you for that clarification, because that was part of my question. So I appreciate that. It seems to me if children are on the SED waiver and then dropped, which is what it says here, they may not necessarily need the IDD services, and I can't see that they should be moved to be priority over those children that have been waiting for a long time. And in looking at the history here, I can see the agency has no plan to amend this policy and process at this time as of November of 2019. And then it was more, as we look down here, that it was like, okay, we'll look at it, we'll consider it, et cetera. As you just stated, you still are of the opinion that they should not take priority, and I have to share that opinion. I don't think that if I were a parent of a child who's been on this IDD waiver for a long time, waiting to get those services, and just because somebody has been SED and may or may not need them, is automatically moved over. So perhaps a discussion could be had, as you said, specify, one, do they really need it? Two, would they moved over to the waiting list, as opposed to automatically be at the top of that list, move to the waiting list, which could indeed help resolve this and come to a compromise of some kind.
Thank you. And Amy Commissioner Penrod can help me. I think the SED child can move to the waiting list, but Amy may correct me on that. She's in the other room. She's probably, I think I can hear her speaking through the walls. But Amy can clarify. Some of these children do probably transition to the waiting list for the IDD, correct? We just don't put them at the front of the line and say, you're automatically now going to get IDD services. And I might clarify, it's not necessarily our opinion that they shouldn't transition. It's just not been our policy for years. For years and years, this policy didn't transition. But you asked us to reconsider, and that's what we've done. We've just been slow at reconsidering. So we apologize for that.
Janice, thank you. And this has sparked several questions. We do have on WebEx, Representative Reese has a question. Then we have a question from Representative Concanon and then Representative Ballard. Representative Reese.
Thank you, Mr. Chair. I think part of what I was going to ask has already been answered, but I do want to ask another clarification. The children that are these are children who are duly diagnosed, correct? They have a severe emotional disturbance and also qualify under cognitive disorder. Is that correct?
Representative Reese, could you repeat your question? We were having volume problems.
Yes, thank you. I just wanted to clarify that the children that we're talking about, these are duly diagnosed children, correct?
In this particular proposal, yes, these are dual diagnosed individuals, yes.
Okay, I wanted to make that clarification because it sounded like maybe Senator Gossage thought that, I didn't know whether she understood that these are duly diagnosed children.
Representative, thank you for your question, and Janice for the answer. And I apologize, Representative Lynn, did you have you're good? Okay. Representative Concanon.
Thank you, Mr. Chair. I've got a couple of questions. So if I think back to this testimony, it seemed to me like when they go off of the SED waiver, then they're losing some services. And then, I mean, is there anything wrong with them already being on the IDD waiting list the whole time that they're on the SED waiver?
And you know, Representative Concanon, I am getting some text from the other room. So let me answer that first from the secretary. She says they can be on the IDD waiting list while they are on the SED waiver. I did not know that. So thank you, Secretary. Amy is going to talk about this later in the day as far as the, oh, nope, that wasn't with this issue. Amy is going to talk, we'll be able to talk about this later today though, but yes, they can be on the IDD waiting list while they are on the SED waiver.
Okay, and then, yeah, I'm trying to think back. Do we have Roxanne testifying any today? Or she won't be here? Okay, I'm just trying to recall. It seemed like it was a heartbreaking story, and more than one. And from having services, and then all of a sudden, you got to go to the back of the line, and you can't have those services anymore. What I'm wondering now is if there's a way to estimate how many would go off of the SED waiver in a year, and how much that would cost, what we could appropriate to keep them on. You know, just what the cost would be to us. And I guess you would call it moving them to the front of the line, but I call it transitioning them into the other care. So,
okay.
Thank you, Mr. Chair.
We can do that.
And kind of touching on that, if you wouldn't mind, Connor, pulling that old testimony from Roxanne and sending it out to committee members. That way we can have it and refresh ourselves with that testimony. Representative Ballard.
Thank you, Mr. Chairman. And actually, I will follow part of Representative Concanon's lead. When I read here who was dropped from SED, were they dropped because they no longer needed these services that we were providing? Were they dropped because we had a time limit that they could be on this particular waiver? You know, I'm not sure what you mean by what they were dropped, because if they had made progress and we don't continue, then they'll regress. And now we have another problem, but do they come back on SED? Because we're saying we're not going to put them on IDD. And even if they were on the IDD list, but they came on and they've only been on 3 years, you still have other people that have been on that waiting list a lot longer than they have. And I agree, they shouldn't just leapfrog over them. But at the same time, if I had a child that was making progress and I was really excited about it, and then they get dropped, I want to know for what reasons. We don't need to know that today. Were they dropped? And if that were the case, where do they go if they have no other place that we can place them? Thank you, Mr. Chairman.
Thank you, Representative. And Janice, thank you for fielding those questions. We are over time, but we have another question from Representative Gossage, or Senator Gossage, sorry.
Thank you. I appreciate the representative that was clarifying for me about the dual diagnosis, and I noticed it said years away. My follow-up question was, the last statement says the transition to the IDD waiver is automatic for individuals on the TA and AU waivers. Could you just tell us what TA and AU waivers are?
Yes, technical assistance in autism.
Okay. And so when it says an audit, it's automatic from what?
So it would be, so if you have a TA child as a technical assistance, which means they are on, how do I say this best, that they have machines that keep them breathing, if you will, every minute of the day. So these are very, very high care children as a general rule that are a TA, and they do transition automatically to the IDD waiver as needed in the autism children. Also, according to Roxanne, I'm going to actually ask Amy, our Commissioner Penrod, to answer that question better for you, Senator, than I just did. But the technical assistance waiver is for kids. We have, oh gosh, I don't know why my numbers are escaping me today. We have, you know what? Amy will have in her testimony today how many kids we have on the TA waiver. And then the autism waiver, we only have about 65 children on the autism waiver.
And so when they are also dually eligible, I'm assuming?
Well, I'm going to be careful saying
Okay.
what the diagnosis is for the
Okay.
TA kids and for the autism kids.
All
I'm going to
right.
be careful with that.
Thank you.
Yeah.
All right. Janice, not seeing any further questions, if you go ahead and proceed.
Okay. The next one is number 7, which was from Nick Wood at Interhab, and this has to do with behavioral health issues for the IDD community. And we are proposing, again, as one of our 10% FMAP bump investment projects, we did include a request to explore a mobile crisis system for the IDD community in addition to what we're doing now for adults and kids. That particular FMAP bump focuses on how we can train parents, but we also acknowledge at this juncture, as we build the CCBHCs, which is our certified community-based behavioral health systems to support the CMHCs, which are our community mental health centers. We do believe there's an opportunity as we build the CCBHC systems that we can somehow include the IDD community in some of that crisis development. We don't have that all figured out yet. I'm going to be perfectly honest with you. We do not have it figured out, but we are hoping to use some of this 10% FMAP money to help us figure out how could we address this concern by Nick and Interhab that we need to have more mobile crisis response system for the IDD community also. That was a really long answer. I didn't articulate that very well at all. So the point is, we hear the IDD community, we hear Interhab, we hear their concerns, we agree with their concerns. We're trying to figure out as we build this mobile crisis system for children and adults with mental health issues, how do we also build a system to include the IDD community and the autism community? So we agree with them. We're doing our best to figure out how that might work, and we're talking to Nick and Matt Fletcher every chance we get. So that's definitely ongoing from our vantage point. I'll keep rolling unless you want me to stop, Senator. Number 8 spans for several pages also, and this is the concern by Nick and Interhab that these are for individuals with IDD who have actually been accused of a crime. And for this particular concern, which we also acknowledge, we've got to get a better handle on this in Kansas. How do we better address individuals with IDD who have been accused of a crime? And I'm on page 11. We are going to bring in, I think it's right at $30,000 in part of our 10% FMAP bump request to bring in the experts to help us with a sequential intercept model, because at that point in time, a sequential intercept model can help address gaps that we have in our systems across the state, including our justice, our judicial systems, and our police force, and what can we do to help individuals with IDD who are accused of a crime and may fall through the cracks. So that's page 11. Number 10, you ask us, you did combine this issue. This is about an Olmstead plan, that Kansas should progress on an Olmstead plan. At this juncture, we are not developing a Olmstead plan specifically. But we are working closely with our stakeholders to enhance community-based services, including our investment projects with the 10% FMAP bump. We would actually ask that this item be removed because of our other opportunities that we are working hard on with this 10% FMAP bump.
Janice, I know you're continuing to work on it, but as long as we're continuing to work on it, I still think we probably ought to leave it on there, so.
Okay.
Thank you.
Number 11 is from Amy Heighton at Tilrick, and she wants to ensure that the person-centered philosophy and planning and services and supports is included in everything we do. We agree with that. We agree. We agree, and we agree. We agree that person-centered philosophy should be at the base of every single thing we do. Number 12 is very specific to workforce.
Janice, I apologize, backing up to action item number 11. You agreed, but what is the action plan other than agreeing? What is the process to do it?
We'll just continue to work with stakeholders to make sure person-centered planning is in every single policy we write. We meet with the MCOs every month, couple of times a month, to make sure person-centered planning is at the forefront. We agree. We agree that person-centered planning is what HCBS is all about. You know, Amy Heighton is asking for a support system, and I'm not exactly sure what that would look like. But for our vantage point, we agree with these conferees on this one. And we share that perspective with the MCOs all the time. I'll move on. Number 12 is workforce, and it extends over to page 16. A lot of concerns about workforce. Again, we agree. Workforce is a major concern in the long-term services and supports world. We have included in our 10% FMAP investment request to CMS that we can actually use approximately 50 million of the 80 million to distribute directly to employers who can recruit new staff or retain current staff. We have not yet received approval for that. We're hoping to hear from CMS soon if they agree with us. We do feel that our employers of LTSS are having a difficult time hiring staff. They have informed us of that repeatedly. I'm sure you've heard it also. You've heard it here. We need to do something to help recruit people to the LTSS world. So our proposal in our investment request to CMS is let us send 50 million, let us distribute 50 million of this 80 million to individuals to recruit them, get bonuses, get raises, or get even temporary raises, help our employers do something to reward their staff and retain their staff. So that is our proposal, that we would use 50 million of the 80 million and send it directly to employers so they can get in the hands of employees and try to get some staff recruited.
Representative Landwehr.
Thank you, Mr. Chairman. So do we have the reason that do we know what's causing this shortage in staff? Is it the pay? Is it the benefits? Is it the hours? Is it the work? Is it, do they have to be certified? Do they have to be licensed? Because everywhere in healthcare, we've got a shortage.
Right.
And depending upon what profession it is, it's a different reason why we have the shortages. So do we not have those answers?
Well, I mean, we hear from stakeholders, we hear from your constituents that it's competition. I mean, there are a lot of reasons out there why it's just a competitive market right now, at least it seems, when it comes to recruiting workforce. What we're talking about here, Representative Landwehr, is, let's get money in the hands of a personal care attendant who doesn't necessarily have to have a license. So no, I don't think there are roadblocks per se that we've created. You can ask the employers more questions, but what we heard from employers when we were talking about this is it's just competition. There are $3,000 bonuses being offered out there, and they don't have the dollars to offer a $3,000 bonus to bring on a personal care attendant. So we listen closely, we believe, to our stakeholders who have said to us, we are having difficulty recruiting people to come into LTSS in general. Can you help us out? So
Well,
that's what
going
this
back to, okay, this item number goes back to November of 19. And in February of 20, the discussion had to do with training sites for CNA classes. So there's a profession. Just to hand out $50 million and say, okay, go out there and try to retain your people, I think there needs to be a little bit more guidance as to what that $50 million would be spent on to make sure that we're actually getting the benefit that we need, which is getting the workers.
Yeah, we agree. Yeah, and we won't actually distribute the $50 million directly. We'll bring in a payroll agent to help us and track, and we'll build some guardrails for the employers. But we also want to be sensitive that it's the employers out there who know how best to recruit and retain. So, I mean, we will have guardrails as far as, how you can use these dollars. But we also want to be sensitive to the fact that we are hearing from the employers out there, and they've got good ideas. So we want to be flexible and help them use this money well.
Okay, and Janice, I know I'm sounding like a broken record, and I'm kind of getting tired of sounding like a broken record. But, okay, so November 19, then we had February 20, that KDADS is currently working with CMS and stakeholders to explore options. June 20, KDADS continues to work with the stakeholders to address these shortages and continues that work through current pandemic. So now we've brought in the COVID issue. November 19, KDADS appreciates the initiative and supports additional collaboration. February 20, KDADS acknowledges the need to increase numbers of direct care workers. We're not gaining any ground since November of 19, Janice.
Well, Representative Landwehr, I will share with you, we were pleased, as I'm sure you all were, when CMS said we're going to increase your FMAP for 10% for community-based issues. I mean, from our vantage point, we've heard this over and over and over, and so have you all. So when they said, we're going to give you a 10% increase in your FMAP, but very focused on community-based services, it didn't take us long to say, we're going to spend most of that money for workforce. We've heard it over and over and over and over again, and we now have an opportunity to make an investment. It's one time. We're not committing you all to fund pay increases, but it is one-time money for us to address this.
But it doesn't solve this issue for long-term with one-time money.
No.
And so to have this issue sitting on this spreadsheet since November of 19 without a long-term resolution, because this is now September 21.
Right.
So we're almost 2 years. No answers, no long-term solutions, a temporary one-time money fix coming in there. And again, I understand, Janice, these are not easy issues to deal with. They're not easy because we know everywhere in healthcare we have a shortage period.
Yep.
And it's trying to figure out how to address it. But this started before the pandemic.
Right. So,
and I think pay's always probably been a big issue in this because if I recall correctly, we're talking pretty labor intensive.
Yep.
Work for individuals and they don't get paid a whole lot.
Yep.
So, thank you.
Janice, we have several questions. We have Representative Reese on WebEx, and then Representative Ballard, then Senator Petty. So Representative Reese?
Thank you, Mr. Chair. Janice, the question I have is regarding, the stakeholders that you've been talking to. Have those stakeholders also employed, the direct care workers themselves?
I don't know that we've had conversation with the direct care workers themselves. No, we've been talking to the employers.
Okay, because I am getting, I'm receiving communication from direct care workers, and about their concerns with the workforce, and so they're looking at it if they're working at work, not just work environment, but their process of being able to receive a payroll check, if that is really cumbersome, they are not going to invite other people to go work for those agencies. And that's what I'm hearing from their all kinds of issues regarding how they track their hours, how many hours they can actually work, who is their actual employer, is the person that the person that they are actually directly working with, or is it the company itself? There's all kinds of those issues that are out that, if the direct care worker themselves isn't being able to easily document their work hours and then get a payroll check or be able to do timesheets, and it sounds like it's a very cumbersome process for that. Each of these employees have very cumbersome ways of being able to document your service work. So you're not clocking in, like with a card. It's a whole different system, and it sounds very complicated. I would be great if someone would listen to the direct workers themselves, and find out what those issues are, because it won't matter how much money we throw.
Yep, we hear you. And we can talk later. I don't know if Commissioner Penrod includes anything about what's called our EVV system, and actually I'm not even sure what that stands for. But Amy might be able to talk later about our system for tracking time when a personal care attendant is in the home of an HCBS consumer. And much of that does come from the requirements of an HCBS waiver. But Amy might be able to talk a little bit more about it is the complexity of clocking in when you go into a person's home, and that is part of the system, yes.
Thank you.
Thank you, Representative Reese. And Janice, our next question from Representative Ballard.
Thank you. Representative Reese touched most of mine right there with the direct care worker, because I can remember testimony before that they weren't able to phone in their hours, and that was during COVID, and a lot of people weren't visiting places at that time. So direct care workers, I think, would be one of those people, whether you brought in groups to talk about it, because actually I believe in terms of the employer, they have a different agenda in terms of what they want them to do. The direct care workers actually delivers those kind of services, which brings me to direct care workforce. Does that mean if we use 50 million, will they go directly, that money goes to the direct care worker, or will the supervisor of the direct care worker be included in that as well? Because what that really says, in a way, that it's not going directly to the people that are delivering the services where we really have the shortage, and the ones that are really having to meet all the requirements, in terms of filling out the forms and everything. We understand you have to do that, but will this just be for direct care or around work care too?
I mean, our proposal is that, our thinking is we will focus this money on the direct care workers. That's the idea, that it won't be for supervisors, it's not for office staff, it is for the direct care workers out there, hands-on, who actually are delivering hands-on services to individuals in the community. That's the idea, that's the proposal.
And part of it, I just have to comment on too, that, you know, if we're at 10 something an hour, then at one point we were at 11 an hour, then we were like 12.25 or whatever it was. Well, whatever that amount is, if we're going to use the 50 million, it seems to me we should be enhancing that salary, not just recruiting other new people coming in on entry level, but try to keep the ones that we have trained that know what we're talking about. And at some point, you know, I think, and I've been told repeatedly, people that are doing the work would like people to ask them, how do they think they can solve this problem? Instead of someone else supervising them, telling them how to do it. I think we keep people there because now they have ownership in it. Someone asked them how we're supposed to. Now, besides staying at home with your children or any of those things, we can't do it. And who are the people who have the most indirect care? It's women.
Right.
We know nationally that over 2 million people left, and you say, well, does that affect Kansas? Yes, it does. Because some of those people at home with their children, some of them can't find child care because the child care facilities are not out there for them right now. So how do we solve that problem? We throw the money at them, it's direct care, but if they can't find anybody to take care of their children,
Right.
and they can't, that's not our problem, right? You would say that's not our problem. But I would say ask the direct care worker what conditions they're working under, and can we improve those conditions? Thank you, Mr. Chairman.
Thank you, Representative Ballard. Senator Petty.
Thank you. Mine's short. I just wanted clarification. Do you have to have CMS approval to spend the 50 million?
Yes.
Okay. So still waiting on that?
Yes.
Okay.
Okay.
Janice, seeing no further questions, you may proceed.
Number 13 is let's see, we combined those. Oh, this was the staffing agency issue and the fact that staffing agencies were charging a higher rate, and that it was becoming a very high rate. From our vantage point, there was a bill that was introduced in 2020 that would attempt to address how the Secretary of KDADS could regulate the supplemental nursing facilities, nursing service agencies. And that was scheduled for a hearing, but then I don't think it did have a hearing, I'm not sure. But from our vantage point, that would require legislative action for the Secretary to be able to regulate how much a staffing agency could charge to facilities, to nursing facilities. Okay, I'll move on. On number 14, the final settings rule, this particular conferee asked that the committee focus on the final settings rule. We are pleased to report that we are making good progress. We have put a lot of resources into meeting the federal final settings rule, which that settings rule, just in a nutshell, basically says, as a state, you've got, I think initially we had 3 years, and maybe now we have another year until March of 2024. We, as a state, have time to ensure that all of our HCBS settings, which means all of our providers who accept HCBS dollars, must meet certain expectations in order to continue to receive those dollars. There's got to be more autonomy in HCBS settings such as assisted living. You've got to be able to have more opportunity to come and go. You've got to have a person-centered plan. So the final settings rule said to states, you must ensure that these settings are appropriate and that they truly do support community-based care. We agree, and we are making good progress. We have had to shift a lot of our resources internally within the HCBS program. We have had to shift those resources to this federal requirement. We also are going to have to maintain the requirement that we have to stay in compliance. Just to give you context, and Amy will be here later. I think, oh, doggone it, I don't know why my numbers are escaping me today. Amy can actually share with you the number of settings we're referring to, and it's a lot. So we are actually having to ensure that, I think it's over 2,000 settings across the state have to come into compliance. So we're making good progress on that federal requirement. Number 15, this was from Mitzi, and she was concerned about more and more facilities may find themselves coming into receivership. That was in 2019. We have since been in the throes of a pandemic, but at this particular time, we still only have one facility in receivership, and that was in receivership prior to the pandemic. We are hoping that we don't have any more buildings that come into receivership, but we do know that there's some concern out there with nursing facilities. There is a lot of stress, and it is particularly due to staffing from what we are hearing. But at this particular time, we have one facility in receivership still, and that's Providence here in Topeka. Number 16, page 21. Haley was not pleased with the way our PEAK program was operating, and I'll be honest with you, PEAK, it's been an acronym for so long, I'd have to go back and check. It is a program that rewards facilities that move, nursing facilities that move toward more person-centered planning, even in nursing facilities, is what PEAK, what its intentions are is to help facilities move in that direction with some money, with some incentive. But over the years, it got kind of stale. And we did receive some requests to revisit it, and we are doing that. So we pulled together, and actually the PEAK Advisory Board was pulled together several years ago, and then we've assigned some new staff to that particular advisory board, and we have begun revising what the PEAK program might look like to incentivize slightly differently. But again, we're in the throes of a pandemic, so to ask a nursing facility to spend their time working with us on this PEAK program has been probably not our best timing. So we are still having conversations with the advisory board, but we're being very sensitive to the fact that nursing facilities are very focused on other issues right now. I mean, they're focused on quality, but we aren't going to necessarily ask them to come to training to talk about PEAK during this particular time. But we are making good progress there. So,
Janice, we have a question from Representative Ballard.
A very quick one, clarification. We only have one, you said, left in receivership, and that's Providence. Is it closed? Does it have people? And are we managing it? How are we handling this receivership?
oh, it's open and it's full. I mean, it's not full capacity. No, yes, we operate it. Yeah, we have a contractor in there who helps us operate under the receivership. Yep.
Thank you, Mr. Chairman.
Senator Erickson.
Thank you, Mr. Chair. Janice, can you tell me, since I'm one of the new people, when was PEAK implemented and approximately how much per year was budgeted for incentives for that program?
I can ask a friend real quick on how much. The PEAK program has been around for, geez, I've been around forever. So the PEAK program, we implemented it under Connie Hubbell's leadership probably 20 years ago at least. And I'll be honest with you, it was a very similar purpose, but the fact of the matter is, the industry has transitioned over those 20 years, and so now we don't need to have that same conversation with nursing facilities about letting people eat what they want to eat, when they want to eat it. I mean, we have less conversations about that now because that's just become the norm, if you will. At least we hope that's the norm in nursing facilities. So the industry has probably transitioned, and the PEAK program was just a little slow to come behind it. So it was a little, I think, stale. And we talked about with some stakeholders whether we even needed to maintain it or rethink how those particular dollars, because I think it's only a couple $1 million. And keep in mind, you know, we spend about $600 million on the nursing facility program. So it's not a lot of money, but it's enough that we felt we could incentivize some buildings to change the way that they deliver services. And I think it was impactful at the time. But this advisory board has given us some good suggestions on how we might change it up and incentivize just a bit differently, even though it's a fairly small amount of money overall. But I can text Brad Ridley and see if he can get us the amount before this afternoon. I'll be happy to do that.
Thank you. Just a quick follow-up. You mentioned the advisory council or board is giving you some really good suggestions. I noticed that the advisory board had been done away with since it's been reinstated. So is there a time frame when that was dropped, and maybe is that maybe why the program has not been as effective, perhaps? Thank you, Mr. Chair.
I think it just became part of our reimbursement methodology, and it just was part of it for years and years and years and years. And I'm not sure, it wasn't our idea, although I think it was a good one. It wasn't our idea to resurrect an advisory board, but at some point in time in the prior administration, someone said, let's bring in an advisory board, and that was, I think, a good idea. It needed to be addressed. We needed to ask the question, is this still working? So.
Janice, I do not see any further questions from any of the committee members, so you may proceed.
Number 17, again, this is from, oh, no, this isn't from Nick. This is from Laura Singer. She had a story, and it was, you know, it was upsetting about an individual who was IDD who did have dual diagnosis. And too much trouble, too much difficulty getting this individual through the system. And we feel at this point in time that, again, this is the sequential intercept model can help us identify where are the gaps. I mean, what can we do? What can we do from individuals that it feels like at times do fall through the cracks? So we are bringing in some folks to just help us identify where those gaps are across our system for those individuals with IDD that are dual diagnosis. Number 18, this was from Linda Mowbray. She talked about change of ownership, that there was some burdensome issues with getting a change in ownership process, and we're not real sure what those issues were. We reached out to Linda and asked her for some additional updates. Haven't received those examples yet, but we do have change of ownership paperwork that comes through every day at KDADS, and we do process those. So we would ask that this be removed. We haven't heard from Linda, and we talk to Linda every week as far as giving us examples. So I think her issues hopefully were addressed, but we never did hear on specific examples. So we would ask that this be removed.
Janice, I think probably before I would be comfortable removing it, I'd like to hear Linda Mowbray's thoughts on this topic for removing it. So.
Okay. Number 19.
Janice?
Yep.
Have you asked her?
Oh, yeah, yeah.
Specifically, and she's refused to give you an answer?
Oh, I don't think she has refused. I just don't know if she's just responded. But yeah, I'm sure Lacey Hunter, our commissioner, would have asked specifically for examples. But we can double. I mean, we talk to Linda every single Tuesday, so we can ask specifically for her to go back to this 2020 example and tell us which one it is. Yeah, but we would have asked, yeah. Number 19, this is it goes several pages across to page 27. And this is about the private duty nursing for children on the TA waiver. The legislature did pass an appropriation to fund private duty nursing for the technical assistance waiver to $47 an hour. So you all did take action on that request. We would ask that this be removed.
That was, Janice, that was action item number 19, correct?
Correct.
Yeah, I think we agreed to off of previous.
We already closed.
Yeah, we already closed that from Sarah's recommendation, so.
Okay, good. On number 20, this individual was asking if we could adopt insulin administration training, and that would require statutory change. And we noted that in June. Number 21, I'll keep going. Number 21 was Mitzi. She would like for the Senior Care Act to be amended to include individuals under the age of 60 who have been diagnosed with younger onset Alzheimer's. This is two things real quick on that. You did appropriate an additional $3 million this past year, which we appreciate. And then also this will be an item that we'll be discussing on the Kansas Senior Care Task Force under Representative Concannon's leadership. So we would ask that it be removed, or if you keep it, then we'll just report from that task force also. Number 22, this has to do with Medicaid expansion being implemented, that Leslie was suggesting that we have evidence-based interventions and programs. We don't have any additional comments on that at this time. Number 22 on page 28.
Janice, if we could just back up just a second. We do have a question on action item number 20 from Representative Landwehr. And then I might have a follow-up question if she doesn't ask the same question I was thinking of.
Okay.
Okay, so on 20, if it's a curriculum change for the CMA, have we requested that? Have we visited with anyone to perhaps revise that? Do we think it's a good idea to revise that, or we just, no further updates, no further updates, no further updates?
Let me defer to Scott Brunner. Scott will be here in a little bit, either now or this afternoon, whichever you prefer, Representative Landwehr.
I think he's standing right behind you. He can, you can use your mic right there if that's all right with the chairman, just to respond to that, please.
Perfectly fine, Scott. You don't have to.
No, you don't have to get up, honey. Oh, okay, that's fine.
Scott Brunner, I'm the Deputy Secretary with KDADS and oversee the licensing operations. We have been talking with our training schools on the CNA side for certified nurse aides on updating the curriculum and the process. That'd be a place to bring this up as well if they think that's a skill that they could train on. As we wrote in the item, there's a limit on what we can do as a CMA in the type of injection, type of administration of medications they can do. So we would need that statutory change, but we meet with them, with the schools every month for the last, through the pandemic, because we had updates for them on a regular basis. We could bring that up at the next meeting and see if they'd be supportive for something for this session.
Here goes the broken record once again. June 20th well, it was actually brought up in February. You guys responded June 20 of that year, and it was said then that the CMA course curriculum would also need to be revised. And then February 21, April 21, and today 21, no further updates available. No, so that tells me there's no action being worked on this issue.
we could revise the curriculum, but we'd have to have enough statutory authority that a CMA could actually do the administration of insulin through a method that they can legally do. So we would have to have the statutory change before we could update the training curriculum.
Okay, so if there's a willingness to change the curriculum, you guys could have introduced legislation or asked for legislation to be introduced, correct? Revise that?
With the timeline, yes, from last session.
Yeah, I'm just, my frustration on this, Scott, and I'm sure the secretary's listening too, is, no action taken on several of these items. It's just no further updates. I'm reaching my limits.
Understood.
But thank you, Scott.
And Scott, if you wouldn't mind, that was pretty much my question, but I just want to reaffirm. You guys will be introducing legislation to address this? Or are you wanting, or would you rather the Bob Bethell Oversight Committee recommend for legislation be drafted for this?
Mr. Chairman, that's your decision. The one, just so that I'm clear with our schools that we partner with that offer this training, that it's something that they would want to be able to do and they can support it as part of their training curriculum. So we do meet with the schools that do CNA and CMA training. I haven't heard that they've objected to it. I've never heard them bringing it up in this whole time either. So I would like to put it in front of them to make sure it's, and I don't know what the obstacle would be or if there would be a barrier, but I feel like to be respectful of their, what they train on and how they do that and what they have the ability to do to make sure they're clear. And then at that point, we could come back to you and ask you to do an introduction, or we could certainly do that as well.
Well, why don't we address it this way then? As the chair of the Bob Bethell Joint Oversight Committee, I will give you guys a friendly request, that by our next meeting, have this answer from your school, so we can put that in a recommendation if we need to introduce that legislation.
Sure.
And that gives you a timeline and that we can meet. Sound good?
That sounds good.
Thank you.
Thank you.
Senator Gossage.
Very quick question. The way I read this, and thank you, Mr. Chair, is that the training they're asking for, because they're saying currently in Kansas, the certified medication aides permitted to dose the insulin medication amount in an insulin pen, but are not permitted to assist the residents in self-administration. So we would be training them to assist that's the training we're talking about. Is that correct?
There's probably something related to the insulin dosage and how they monitor the resident, but in general, yes. We'd be training the CMAs to be able to assist the resident.
Them to self-administer.
I believe so, yes.
'Cause that's the way I read this. So that's the training that they're saying they would be willing to do, is how to train somebody else to do it, to self-administer.
Again, I'm not sure. I'd want to ask
Okay.
the schools to make sure that's their understanding as well. But I believe that your chain is correct in terms of
Okay.
what the skill would be that
Thank you.
we'd be training on.
Thank you, Mr. Chair.
Seeing no further questions, Janice, you may proceed with your action items.
Well, and I'll probably have Scott stay close because we're getting close to some of his issues. 21 was the Senior Care Act, 22 was Medicaid expansion, 23 was KDHE's, 24 on page 30 is very specific to, Scott, your infection control practices and visitation. Do you want to speak to that, Scott, as far as updating visitation? I know you're going to do that this afternoon, so. Scott will have an update this afternoon on our visitation for nursing facility guidance. It was reviewed in March of 2021, and there will be additional information this afternoon. If you want to hear from him now, we can do that.
We'll wait for this afternoon on that.
Okay. Thank you. 25 on page 32 was Sean Gatewood was asking us to establish a Money Follows the Person steering committee comprised of stakeholders. In part of our 10% FMAP bump request, we did include a proposal for the MFP. Let me double check that. Let me double check with Amy Penrod on that one as far as the project we have for MFP and our list of 12 projects. I can't recall the details, but we will get with Amy on that one. I'm going to keep moving. On number 26, this was from the Centers for Independent Living that we're proposing that they have a designated source of support or a line item in the state budget. We would agree with them that they don't currently have a line item state budget in KDAD's budget. Sorry, Senator. You want me to stop?
No,
Keep
you
going?
can proceed.
Okay.
Yes, thank you.
Number 27 is, Matt Fletcher was asking for the 8.9 million SGF to be included in 2021, and you all did include a rate increase for IDD services in the 2021 and 22 budgets. We would ask that number 27 be removed. You all did provide a rate increase. Number 28.
Janice, if we could pause right there just for a second. I believe that is something without objection that we could remove since we've already taken action on that. Okay, so no objections. We will remove action item number 27.
Okay.
We have Senator Erickson.
Thank you, Mr. Chair. Nothing on 27, but I noticed on 26, Janice, you're also requesting that to be removed. Is that correct?
We would request that that be removed. We would agree that there is not currently a designated line item in the state, in our appropriation for Centers for Independent Living. We agree with that. And that would be up to you if you all choose to appropriate a line item for the Centers for Independent Living.
Representative Carpenter on action item number 26. Do you have any objections to having that one removed? Yes, go ahead and proceed, Janice.
Okay, number 28. This was from an individual who was concerned during the pandemic that nursing facilities needed some additional funding, and you all did. And our September response should have said, and this is my oversight, should have said you did include a $15 a day appropriation that we did get distributed to nursing facilities. So that did happen. We would ask that this be removed, and we can also update the spreadsheet. The $15 a day you did appropriate, it has been distributed.
Committee, do we have any objections of removing action item number 28? Okay, seeing none, we will remove action item number 28.
Thank you. 29 and 30 and 31 were KDHEs. 32, it feels like 32 is similar to what we heard in the one we just removed, in that we did provide $15 a day. You all provided $15 a day as a pass-through, if you will, for Medicaid reimbursement to nursing facilities. In response to 32, we would also ask that that be removed. And I should have noted the $15 a day in our response here also, so that was my oversight.
Janice, on 32, we'll come back to that one as well.
Okay. Number 33 was KDHE, 34 is ours, and I will definitely ask Scott to respond to this one because it has to do with temporary aids, if you want him to do that now or this afternoon. I think it's in his presentation. It's not in your presentation? Oh.
Well, if it's not in his presentation, we probably won't hear from him, so we'll probably all take advantage right now. So, Scott?
Thank you. Item number 34 is about the use of temporary aids during the state of emergency. The governor issued an executive order that created a new category of worker in facilities called the temporary aid. That expired with the executive or with the emergency declaration, and we can't extend it under our current regulations without either an executive order or an emergency declaration. So that is something that the Leading Age and the other trade associations have asked us to do, or asked the administration to do, and we are trying to figure out if there is an executive order language that we can use that would allow that. But where this was authorized, it was tied to the emergency declaration as well, and we still think it's tied to that, whether the governor has the authority to issue an executive order on her own.
Scott, just a question off of that. Is their issue then resolved since there's no emergency declaration? Is this a continuing issue that they need maybe legislation to look at? Or it seems, and I apologize, I'm not too much on legislating with a pen and paper. I'd rather go through the legislative process, and it seems like that's more legislative than executive order. That maybe that's something we should probably take a serious look at as a body of legislators.
Mr. Chairman, to answer your question, you could certainly address it through legislation if you chose to do that. The difficulty that we have without the emergency declaration, we can't create a new category of, they weren't really licensed, but they were authorized. They had some training required, and they were able to provide some services and do tasks in facilities that otherwise they wouldn't have been able to without some licensure. So or where we're pinched as an agency is we can't create a new licensure class certification grouping without statutory authority to do it, or then we had that kind of executive authority through the emergency declaration.
So adding on to the other request that I had given you on the insulin injection, could you do the same with this one as well? See if that's something we need to proceed with or look into, or just, are they satisfied with where we're at?
I won't speak for them. I don't think they're satisfied where we're at, because what this temporary authority or temporary aids allowed were people that were already working in the building. So a dietary aide or somebody else who who didn't have a CNA certification could do some direct care tasks that they otherwise wouldn't have been able to do without that CNA certification. So I'm not sure as an agency, for us, we'd rather have more people certified as CNAs to be able to have that licensure category that already exists, rather than create another tier of aid that can work in a facility. But there's certainly a policy debate to have there of what the right scope of services are and how that fits together. But I think coming out of the pandemic and sort of the emergency needs that were there, we can move people through CNA classes. Those are available. We can get more people certified. That's less of an obstacle, but it is a policy question. Happy to engage, and you should probably ask the industry as well of where they'd like to fit with this scenario as well.
Yeah, because whether we like it or not, workforce everywhere is becoming a issue and a problem, and sometimes, we probably need to start being more creative on how we do things. So I think that's something we should really look into seriously about moving forward. Question from Representative Lynn.
Thank you, Mr. Chair. I'm curious to know how many of these temporary aides have taken the courses that are available to them to become the full nurse aides, or to get the full nurse aide status?
Representative, I'll look and see. The temporary aid was I don't want to use the word certification, was an authorization that was done at the facility level. So the facility attested that they had a worker that completed the 8-hour course and could do this work, and so they were working within the auspices of that facility. We didn't ask for that information. We didn't want to make it more complex. So I don't know if we have a way of looking at people who have applied for a CNA course or are taking a CNA course if they show that they had this experience. We were counting some of this time towards their CNA certification, but I'll have to look and see if we've got that recorded somewhere in our current cohort of people that are in CNA classes.
If I may follow up. So it looks to me like that was the point of number 34, is to allow for these temporary aides to first be able to work, but then to receive their full nurse aide status. It looks to me like that is the point of number 34, not to necessarily continue having the temporary aide option, but for them to be used during the pandemic that could become full nurse aides. So I guess that's what I'm wondering, if for that reason we need this, for if we need the temporary nurse aide to be still an option.
I can figure out if we asked, or we have a way of counting this. We did want some of that temporary aid time worked to count towards the CNA, or at least be part of that, get people interested in the profession, and then advance through the certification. So I'll check and see if we've got that recorded somewhere for the counts. Again, it is a policy question about, do you want to have a pre-CNA or a CNA light category of licensure or certification? That's something we haven't pursued because we're trying to keep people moving through the CNA process. So it is a good policy question. I'll see if we've got the information that you've requested about how many people actually transition through.
Thank you, Mr. Chair.
Thank you, Scott. Janice, you may proceed.
Thank you, Senator. Number 35 on page 38, we're getting close here to the end, is about the mobile crisis system again. Nick brought this up again in 2021, Nick Wood, and again, we agree that we are committed to building a mobile crisis system, a mobile crisis response system in our state, and we do hope to include the IDD community. Will continue to work with InterHab and our IDD network and continue to review what other states have done successfully to make that happen. Number 36, this was from Janet Williams, and she had concerns regarding the brain injury waiver, and she did not want to create a waiting list, and she believed that there were some policy changes that could happen to avoid a waiting list. We have pulled a work group together, and we've met with them in the last quarter several times. We've developed a preliminary list of recommendations, and those will be shared with you this afternoon, and I think you've asked us to share those with you frequently. So you will hear more this afternoon from Amy Penrod on the work of that particular group. Number 37 is, I think that was actually KDHE. Well, yeah, we should have responded to that also. This was from Linda Mowbray, that she feels that the assisted living, and these are for the adult care homes that are not nursing facility, she feels that there is uncompensated care, but it is because of the way eligibility is determined, which is a KDHE issue. And they did respond in April at that point in time. I don't know if Sarah asked for that to be removed or not. The feds do not actually allow for a plan of care. Well, HCBS and CMS do not allow for backdating, if you will, for community-based services. So let me see how H&E responded. Right. So the nursing facility eligibility process works different than HCBS, and Linda is referring to HCBS if an assisted living provider, for example, does accept HCBS customers, and all don't, that she feels there is uncompensated care, and it does have to do with the eligibility system, which is federally driven. Number 38 with Haley, she asked about whether we could do more, and I may need Scott here too, on the licensure side for the number of licensed beds being reduced more often, more frequent than the current statute allows. And I don't know, Scott, whether that would require a legislative change in order for that to happen. I don't know if you want to.
It's quarterly based on the cost reports, isn't it?
Is it quarterly versus twice a year?
That's for the quality assessment.
Oh, this is for the tax? No, no. This is just decertifying license. We can follow up more on number 38. Let
And
us do
Janice,
that.
while we're going to do that, we have a question from Representative Carpenter.
Okay.
Thank you, Mr. Chair. I think if we could do a little bit more of a dive on 26, going back to that, leave that on there. But on this issue here, kind of like what you had mentioned earlier on several other issues, if it does require legislative action, then I would suggest that we put a placeholder on there to see what exactly legislatively we need to do to allow that to happen. Thank you.
Will, did you look at 32?
It's 38. Oh, I thought it was 26. Oh. Well, I was sleeping, I guess.
We'll come back to 32 then?
Yeah, come back.
Okay.
Okay.
Janice, go ahead and proceed.
Okay, let's see. On number 39, Sarah already addressed number 39 with the protected income level. And then number 40, I'm definitely going to defer to Scott. This has to do with the state hospitals and understaffing, which was from Roxanne. And Scott will address that this afternoon, but it's here also. This is your racist. What? It is in the slide deck? Okay, and it is in the slide deck this afternoon. So at that point, I think all the other three are MCOs, or the other two are MCO related.
Janice, thank you for your update on our action items. And just as going to strongly encourage and request any agency or MCO that has action items, going forward, instead of we're going to follow up on that, I think we really need to have a good roadmap in place of more detail of what our response is going to be, what the solution is. Is there a solution? And what type of time frame we are looking at in wrapping this up. You know, if it's something that we don't agree with, we need to really have a deeper discussion on should it be an action item if it's something we're not really wanting to move forward, instead of keeping the same stuff on for 2 or 3 years or even a year. So any conferees that have action items, I'm strongly going to encourage you from here on out in future presentations that you have a clear and defined roadmap on how you're going to get this action item removed off of there. So thank you for that.
Thank you.
Do we have any further questions for Janice before we move forward? Okay, so we do have an objection to removing action item 32 as well, Janice, so we'll leave that one on there as well.
Okay.
Okay. Not seeing any further questions, no questions online. Oh, sorry, Representative Carpenter.
Thank you, Mr. Chairman. Sorry about that. You were talking about the study earlier, the RFP, and you mentioned a price tag of $2 million. I'd like some clarification on that. That seems outrageously high.
Yeah, and I did get clarification. It is 1 million.
That still seems outrageously high.
Okay.
Senator Petty.
This is really a question for Representative Carpenter. So why are we keeping on 32? It's the $15 a day. $15 a day was added. We did have legislative action. Why are we keeping it? 32.
I think that it goes just to the fact that we need to keep workforce and workforce development on the top burner. I'm not sure that there's any action. Where did you see $15 an hour?
No, that was the answer, that was the information that was provided by
Oh,
Janet.
okay, okay. I just think it needs to be on the burner as well as, you know, it's kind of interesting, we talk about direct care workforce and we talk about this workforce, and it's been going on way before COVID, and COVID has brought it, you know, to that fact. But anything to do with workforce, I think that we need to keep on a burner and try to address these issues. A lot of it's competition, a lot of it's all kinds of things, and there's no easy solution, but I think anything that we can do to start bringing workforce issues to the forefront is the way we should go.
Okay.
Representative Ballard.
Thank you, Mr. Chairman. I can make it quick, and I'm in favor of keeping 32 on. And part of that, for me, is that we look at it and say COVID pandemic. Well, I don't consider that we're totally out of the pandemic right now. And I think with the Delta variant, and then you don't know what else is going, I think we need to have something ongoing just in case we need to fall back on it. I'm agreeing with the chair that when we talk about workforce, the same as we're looking at other things that, especially around virtual clinics or the courses and extending temporary and those kinds of things, I just don't think we're ready to just let it go yet. Thank you, Mr. Chairman.
Not seeing any further questions. Janice, thank you for
Thank you.
your update. Committee, we will now hear from a representative of our MCOs. They're going to combine their presentation on the action items.
Yes, I did. Thank you. I just think I'm the fastest talker of the three, so thank you for having me here today. My name is Carrie Kimes. I'm the Director of Provider Relations and Network Strategy for United Healthcare, and I'm going to provide a combined update for the MCOs today on our two open items. Item number one for the MCOs was a concern from a conferee in regards to approvals for home modifications for IDD members. The general concern was there was not a consistent process or approval process used by our care coordination staff. The MCOs have met, compared our processes, put together a streamlined process that we all three can agree on, and that is now in the hands of KDADS to review and approve so we can start using that consistently. So we're now just waiting on approval so we can put that into implementation. So any questions on that item? Okay. Item number two was a network adequacy concern in regards to sedation dentistry and DME for our waiver members. All three MCOs provided specific information in the deck in regards to how members can have obtain access to current providers who offer sedation dentistry in each of our networks. That they can obtain that from either calling our member services teams or their specific provider advocate, or in the case of waiver members, their care coordination staff can work with them directly to connect them with a dentist that does sedation dentistry. We also provide specific information about DME providers, which is durable medical equipment providers who can serve waiver members, and how they can obtain that information. So any questions about network adequacy for sedation dentistry and durable medical equipment providers?
Senator Petty.
Thank you, Mr. Chairman. I actually have a question back to the first one.
Sure.
Slow thinker. So you're working, the MCOs are working to have a consistent process so that each one won't be different. How about the timeline? Are you also looking at response timeline so that it's in, what I've heard is that services are being provided, but yet there's no approval. And then once there's denial, they already have somebody who's in crisis, that the services are being provided already.
Yeah, so the hope would be that the process overall would be consistent. Timelines and approval timelines, the goal would be that those would also be consistent. The one thing that will vary a little bit is if there's requests for documentation or we need information returned from the provider. If it takes one provider 3 days to return it, another provider 5 days to return it, there may be a little bit of variant between the approval timelines, but yes, the goal would be for it to be consistent across the board.
Okay, so that means you are looking at an improvement in the timeline of response?
Yes.
Are we talking about hours? Or are we talking about days still?
I think it's still going to be days in regards to the amount of time it takes to receive all the documentation needed and have it fully reviewed and make a determination. These specific requests are for home modifications. And so making sure we have all the necessary information, have contractors' information to make sure that what they're needing and it's sound, we're not going to do damage to the home, things like that. It's important that we thoroughly review that. So obviously we want to do that as quickly as possible, but we want to do a thorough review in the amount of time that we need to make sure that we're not doing harm to the home or something that's going to cause more harm than good.
And do you think you're going to have that coordinated effort by the time we meet again?
I would hope so. We've got the streamlined process agreed upon between the 3 MCOs. We've submitted it to KDADS for approval, so hopefully we'll get that back and implemented well before the next meeting.
Thank you.
Seeing no further questions, you may proceed.
That was it. So unless there's new items for us.
Okay. Committee, do we have any other questions or other new items for any of the MCOs that needs to come about? Okay. I'm not seeing any. Thank you very much.
Great. Thank you so much.
Committee, we are, and for those listening online, just for the record, this will be the record only. We are going to move the 10 a.m. and 11 a.m. conferees instead of working through lunch to tomorrow after 2:30. This has nothing to do with the chairman's inability to keep the meeting on time. Just want to make sure that this is the for the record part, but it has more to do with it's almost lunchtime. And also, I'm going to also blame this on Dr. Norman. Today is his birthday, and he probably should not be testifying on his birthday. So that's the real reason. Has nothing to do with the chairman's inability to run a meeting on time. So hopefully there's no objections to us changing the agenda. And with that, I don't think we have anything else before lunch. So we will recess and be back at 1 p.m. sharp. So everybody, thank you. I trust everybody had a good lunch and is ready to get back and get into business. Committee, first up, we're going to have an overview of maternal health supports with our KanCare system. Our first conferees will be an overview of MCO programs and supports from Dr. Muna Anshwat, Chief Medical Officer of Aetna.
Thank you, Mr. Chairman. Would you like me to share my slides?
Yes, please.
Can you see my slides?
Yes, we sure can. Thank you.
All right. My name is Muna Anshwat. I'm the Chief Medical Officer of Aetna Better Health of Kansas, and I'm presenting today on maternal health programs at Aetna. As you all know, pregnancy can be difficult and stressful for mothers and families, especially for a new mom and those with chronic health conditions. Aetna Better Health of Kansas offers comprehensive programs to support the moms and the baby's well-being. These programs that are listed here on this slide are currently in place, and I will be providing more information on during my presentation. But before I do it, an overview of the programs, I wanted to share one of our members' experience to demonstrate the great work our care managers team provide. Julie is a single mother of 3 and currently pregnant. She suffers from brittle diabetes and depression. She has missed so many appointments and lost contact with her physician. As part of our maternity program, Chandra is one of our care managers, reached out to Julie. Chandra found out that Julie had so many challenges. The most important for her was providing healthy food options for herself and her children. So Chandra was able to connect with community services and provide food by that very next day. She also coordinated with DCF to reinstate her food stamps and enroll her in the WIC program. Chandra continued to call Julie several times a week as part of our intensive care management program and helped her schedule appointments with her OB-GYN, as well as with the community and mental health centers. Chandra, being aware of all the programs that we currently have with Aetna Better Health, Julie had expressed an interest in pursuing GED. So Chandra was able to provide that information on the GED assistance that we currently have. Feeling more supported, Julie now is setting new health goals and wellness goals, positioning herself and her family for continued success and well-being. So I will start talking about the programs that we currently have. The member incentives are offered for a variety of activities, not only resulting in valuable rewards, but also to establish some consistency of care. Some of our member incentives include a gift card for completing the first visit and notifying the Aetna team of the pregnancy within a specific time frame. We also offer gift cards for doing a dental exam during pregnancy. And then we have multiple compounding gift cards based on continued monitoring visits during the pregnancy. And these gift cards can be used towards various baby gear like strollers, cribs, car seats, and diapers. Additionally, our members have convenient access to resources such as access to an in-home pregnancy testing, which saves the member a trip to an urgent care center as well as a trip to the doctor's office. And also it allows our care managers to reach out to check on the results of the test. So if positive, the member is enrolled in care management. We do health risk assessment, and patient or the member is assigned to a level of care management based on the risk factors. Our member support services are available 24/7 to answer any benefit or incentive questions. We currently have educational campaigns that are designed to support moms during their pregnancy and post-delivery. We provide also information related to well baby visits. So our campaign uses different modes of communication, which include direct mail, text messaging, live person-to-person calls, interactive voice responses, and an Aetna pregnancy support microsite that is currently active. All identified pregnant members are assigned to care management. We have 3 different levels. The intensive care management level is as members such as Julie and members with history of chronic illnesses and those we designate as high risk based on their risk assessment. The supportive level includes members with history of complications with previous pregnancies and those pregnant members under the age of 16 and over the age of 36. While the population health level includes all other healthy members. Our care managers do regular reach out to all the members and can move them from one level to the other based on their risk level. Those who are enrolled in intensive care management are followed for 18 months post-delivery, while those in the other supportive and population health are followed for 12 months. As part of our comprehensive maternal health program, we train our staff and educate them to provide them with the resources to support our members. And this is accomplished by providing up-to-date desktops, member incentives, prenatal and postpartum support. We have job aids, and also we have continuous improvement projects to identify barriers and opportunities. The goal of our maternal health programs is to educate our pregnant members on the importance of prenatal visits, their postpartum visits, and well baby checkups for the first 15 months of their lives. Our care management team currently follows 800 expecting mothers. 30 of them are in the intensive level, and these numbers are increasing monthly. We are tracking our quality metrics, and for the first quarter after the full implementation of the program, we saw a 2.5% increase in the timeliness of our prenatal and postpartum visits, and a 5.3% increase in the well child visit up to 15 months. We at Aetna Better Health, we are committed to always looking for opportunities to enhance our maternal health programs. So in the next 2 years, we will be implementing additional programs, which include remote patient monitoring, focusing on members with high-risk pregnancy, and an additional program with nurse-family partnership to provide visiting nurses to women with no previous live birth, most of whom are low-income, unmarried, and teenaged. And with this, I end my presentation. Thank you for allowing me to present, and I'll stand for questions.
Dr. Answat, we appreciate that presentation. It looks like we do have at least one question from Senator Petty.
Thank you, Mr. Chairman. I'm just curious as to, this program sounds very impressive, but how have you seen your numbers increasing from, say, a year ago, 2 years ago? Or is this?
Absolutely. We actually started tracking a little bit more. In fact, we've consolidated a lot of our maternity programs back in March of this year. And we've been tracking on a monthly basis, and we've noticed a huge increase in the number of members. We are committed to do outreach to all our pregnant members. So our care management team is working really hard at, accomplishing that goal.
And will you be able in the future to provide us, stats on those numbers of as you see your program increasing, or if it stays stable, or if you see that you're meeting the needs of the majority of your mothers?
Absolutely.
Thank you.
committee. Not seeing any further questions, we will now move to our next conferee, Ronnie Zaletel, Vice President of Population Health with Sunflower, and she is presenting virtually. Ronnie, welcome to the committee.
Hello, are you able to hear me?
We are, yes, thank you.
Awesome, thank you so much. And I apologize for not being there in person, but I appreciate the opportunity to present to you, the chairman and the committee, an overview of Sunflower Health Plan's maternal health program. As you mentioned, my name is Ronnie Zaletel. I'm the Vice President of Population Health here at Sunflower Health Plan. Our program, which will start on the next slide, and Stephanie's helping me out there with the slides, so I appreciate that. Our program, Start Smart for Your Baby, incorporates several concepts focused on improving the health of mothers and their newborns. We utilize a multifaceted approach to improve prenatal and postpartum care, including member outreach and incentives, educational and wellness materials, care management, provider incentives, and support of the appropriate use of medical resources. Start Smart for Your Baby is a 10-plus-year-old evidence-based program. The overall goal of the program is to reduce pregnancy complications, preterm deliveries, and infant diseases through early identification of pregnancy, member outreach, and member case management and/or care coordination activities. Our clinical programs team utilizes the Identify, Stratify, Manage, Measure, and Disseminate model to implement our mission of advancing health outcomes for our members. The Start Smart for Your Baby program consists of identifying pregnant members, stratifying them by risk level and impactability, providing care management, care coordination, disease management, and intervention as appropriate, and providing health education for our members. We're able to identify members that are pregnant through notification of pregnancy, historical claims data, and the state eligibility file. Sunflower Health Plan utilizes a proprietary stratification tool to assist the health plan in identifying members that are pregnant or potentially pregnant, along with any factors that indicate a member has physical, social, or behavioral health risks that may lead to a poor birth outcome or experience. Sunflower's care management team offers case management enrollment that connects our members to an OB, or obstetrical nurse specialist. The OB case manager works one-on-one with the member and care team to develop a person-centered care plan, assist with care coordination to connect members to providers and social support services and programs if SDOH, or social determinants of health needs, are identified. Social determinants of health needs may be related to food insecurity, housing, or potentially transportation. Upon notification of pregnancy, our members receive a Start Smart for Your Baby mailing that includes a welcome letter to the program, a mother's guide to pregnancy book, and a wellness survey to identify signs of perinatal depression. In addition to care management and educational materials, our case management team works directly with members and providers to support the use of 17P as a form of treatment that may help some women reduce their risk for a premature birth. 17P is an injectable medication that potentially decreases the risk of a preterm delivery. Our Start Smart for Baby team members have access to extensive reports and clinical dashboards that provide real-time data. These reports identify members that are pregnant, and if there is a notice of pregnancy completed, number of live deliveries per month by provider by county, percent of C-section deliveries, and the number of NICU, or neonatal intensive care unit admissions, and also trends related to specific providers and member demographics. We also track which of our members receive care throughout their pregnancy and post-delivery. These are just a few examples of the reports and data available to our clinical team to assist us in supporting our pregnant members to promote healthy birth outcomes. Early identification of pregnant members and their risk factors is the key to better birth outcomes and is an essential component of our Start Smart for Baby program. Assessing risk in pregnancy, help to predict which women are more likely to experience adverse health events. Timely completion of notification of pregnancy has a direct correlation with decreasing low birth weights, most likely due to the interventions triggered by high and medium risk members. The notice of pregnancy, or as we refer to it, the NOP, is very important for several reasons. It enrolls members into our Start Smart for Baby program, so it begins that connection and education. It identifies risk for a poor birth outcome. It collects the member's due date, and we also received updated contact information, which is very important. The notice of pregnancy can be completed by the member or their provider and can be submitted through web portal or can be completed manually and faxed and mailed to the Sunflower Health Plan. Notification of pregnancy assessment captures key characteristics and combined with claims data generates a proprietary risk score. Risk factors are assigned weight and add up to equal a total risk score, placing that member in 3 categories, potentially low, medium, or high risk. Each risk score has an associated reason for that risk level. For example, chronic illnesses such as diabetes, or a history of substance abuse, or potentially unstable housing or homelessness. This level of detail helps us determine which individual of our care team would best support the member's need. The risk levels also assist the health plan in prioritizing which members need outreach and the time frame to complete that initial outreach. This pyramid provides a summary of the variety of Start Smart for Baby interventions offered to our members. The bottom of the pyramid indicates the interventions that all members with a notice of pregnancy and that are pregnant will receive. Educational materials, also text and email program participation, and a breastfeeding support program. Members with social needs such as transportation have access to care coordination, or if they need assistance with referrals to other support programs. High-risk members who have a medical or behavioral health need qualify for care management, and members who've had prior preterm delivery and our 17P candidates qualify for a more intensive care management program. But all pregnant members can contact our member services and care management team with questions or to request assistance with finding a provider or to access a care coordinator to assist with referrals for social supports. The Start Smart for Baby program has several initiatives that are coordinated directly by the health plan, including our pregnant members do qualify for incentives by completing a notification of pregnancy and for attending their postpartum doctor visit within 4 to 6 weeks after delivery. Our community relations and member connection representatives host community events such as baby showers and birthday parties. We have a puff-free pregnancy smoking cessation program that can help members stop tobacco use. And the perinatal depression screening program is in place to screen members for perinatal depression, as well as educate members in the perinatal period about the risk of depression, the signs and symptoms of depression, and accessing services for treatment of depression. In conclusion, there is published data that confirms the notification of pregnancy and the Start Smart for Your Baby program has the biggest impact on decreasing the number of low birth weight babies and documented a statistically significant improvement in delivery outcomes. So that concludes my presentation as well. I'd like to thank you for your time today and the opportunity to provide this high-level overview of our maternal health program at Sunflower Health Plan. And I'm open to any questions if you have any.
Ronnie, thank you for your presentation, and we do have at least one from Senator Petty.
All right.
Thank you. And thanks for your presentation. I just have a couple of questions. So you mentioned that this has been going on for 10 years. I'm just curious, so, and you mentioned several ways that notification comes about. So it can be directly through the participant or through their provider. Is that correct? Or their doctor?
That's correct. Their physician, their provider can make that referral or complete that notification of pregnancy, as well as the member themselves can actually complete it through the portal or call in to talk to one of our care managers and complete that. As well as we have our member services team and that can if they call in with a specific question and we know they're pregnant, we can route them to help one of our case managers complete that notification of pregnancy. Because we really feel that that's the core starting point, to have that information, because it does give us valuable information on how to best support the member and hopefully, encourage them to participate in early prenatal care, as well as help us know how to support them in any potential challenges they may be having, whether they be physical, behavioral health, or just from a social support standpoint, to engage early in supporting those.
What happens if you get notification of a pregnancy, but you don't hear from the mother-to-be?
Well, that's a great question, because outreach and engagement can be a challenge, especially to be able to reach those individuals. So what we do is, once we have that notification of pregnancy, at minimum, they will receive that mailing. So they do get an initial letter talking about, the program and the benefits and the things that are important as part of prenatal and postnatal care. And so that's at least the starting point. So we know if we have that notification of pregnancy, that mailing at least is getting out. But we do, based on, as I mentioned, their risk level, we do make in-person outreach, as well as we do use other type of email, mailing, and text messaging to try to engage that member and to reconnect with case management, especially if they're in that moderate and high risk notification area.
So only if they're in the high risk or moderate to high risk do they get a personal notification? Otherwise, it's just a mailing?
No, what I would say that members that, based on notification of pregnancy, that do fall into the low risk category, they do receive that mailing in kind of a general population outreach, right? So they do receive the mailing and all of those other notifications that do give them the access and the opportunity to reach into the health plan if they have specific questions. We do focus our specialized resources more on outreach for members that appear to be in a moderate or high risk category. So those individuals do get more of that direct in-person contact. But I think the other kind of important thing is too that we look at is that at any given time, based on a claim or something that comes in, an individual could go from low to moderate. So we do monitor that as well, because based on their course of pregnancy and things that are happening, we're able to track that. So if someone moves from low to moderate, then they would then get that in-person outreach to engage and encourage them to participate in working with one of our OB nurses in case management. I hope that answers your question.
That helps. You did provide statistics about improving the delivery outcomes. Are those based on just this last year? Or are they a comparison to past years?
This is actually just general kind of overall based on some studies that have been completed with the program. So these don't necessarily reflect Sunflower Health specific statistics. It was just based on a white paper and study that was completed. But we do have the ability to provide that type of tracking and that type of information specifically.
So you do have specific for your program?
Yes, we do. Mm-hmm.
Thank
you. As
well
as I think, absolutely.
Okay, Ronnie, thank you very much. I don't see any further questions from any committee members. So committee, we will now move on to Lucia Jones Herrera, Senior Program Manager for UHC. Lucia, welcome to the committee.
Can you guys hear me now?
We can.
Okay, sorry, I was trying to use so that you could not hear my dog barking, but it's not working, so you may hear my chihuahua, which is okay. Can you see my slides?
Yes.
Excellent, thank you. Let me just move this. All right. So good afternoon, Mr. Chairman and representatives and everyone else that is listening to me right now. Thank you for having me. My name is Lucia, and I oversee our social determinants of health initiatives and our maternal program. And I like to move around when I'm talking because I get nervous when I talk. So today, like my colleagues, I'm going to share with you about our strategies to address maternal and infant health. I like to start the conversation talking about why we do the work that we do. And this is the only part of the presentation I think I'm going to read. So here at United, we are committed to improving maternal and infant health outcomes with a focus on addressing racial and ethnic disparities by addressing those barriers to care and wellness, as well as being intentional at connecting and developing those trusting relationships with our members and also with our clinical and community partners. So what is that we do? The name of our program is Healthy First Steps, and it's a program designed to address the needs of vulnerable populations and promote healthy pregnancies in meaningful ways. And I know you have the presentation, so I'm not going to read everything that is there, but the main goals or the aims to the program are to identify the pregnant members as soon as possible, reduce those health disparities and barriers to care, increase the member and provider engagement, increase the prenatal and postpartum visits or the prenatal and postpartum care, improve the members' experience through the process, because we know the system is complicated. We know it's complicated to deal with insurance companies too. So we want to make sure that the member has a good experience through their pregnancy and postpartum. And we would like to see, of course, as a result, a decrease on preterm birth, NICU admissions, decrease low birth weight, mortality, infant mortality, and maternal death. So to achieve these goals or aims, we have different strategies in place. And number one strategy is that of early member identification. So we know that timely and systematic identification of members who are pregnant upon enrollment or who become pregnant during their coverage with United Healthcare is critical to successfully provide timely care and achieve those optimal outcomes. So we have a risk certification process that determines whether the member is considered low risk or high risk. And this process or certification process implements and maintains identification methodologies that address that comprehensive and holistic needs of the pregnant members, including those medical, social, behavioral, and risk factors, as well as their engagement in obstetric care. Now, we also have incentives, and that's the second part of that slide, the obstetric risk assessment form, I'm sorry. So we have incentives in place for providers who complete and submit what we call the OBRA form. And this is very helpful for us to identify members early in their pregnancy, especially those that are currently in our program and become pregnant and so they are not enrolling because of their pregnancy. And then when looking at utilization management, some of our members may not want to work with us. Some of our members, like it happens with our colleagues, with the MCOs, we are not able to reach everyone. However, we continue to monitor their healthcare utilization, and we receive alerts if a member goes to the emergency room or is admitted to the hospital. And if those visits to the emergency room or to the hospital are for reasons or events that are outside of what we consider a normal pregnancy, then we'll reach out to those members to see if there is anything we can do at the medical level or at the social level to support them. So another way to identify our members is that the members can refer themselves to the program. Every member that is identified as pregnant will receive some type of outreach. Everyone gets the welcome booklet and everyone gets a phone call. Now, a member, again, can refer themselves, a provider can refer the member, and also community partners or family members. Another of the strategies is that of member engagement. So we identify the member, and then we try to engage with the member. So we have what we call our HARC team, which is the Hospital Assessment and Reminder Center. And they conduct all the telephonic outreach as quickly as possible upon notification of the member pregnancy. So in that phone call, they provide all this general information about our program. And they also conduct the first maternity risk assessment. So based on that assessment, a couple of things can happen. First, if the member doesn't have an OB provider already established, they will help the mom establish that first. Then if the mom is identified as a high-risk member, they will be referred to care management. And then if the member has any other needs, more in the social determinants of health spectrum, some of those issues, some of those needs they will try to address them during that phone call, if that makes sense. So the other part of the engagement is that members in general, either when they call or when the maternal team reaches out to them or when the HARC team is talking to them, we will invite them to participate and enroll in our Healthy First Steps rewards program. So this program is an incentive program, interactive incentive program that encourages members to make and keep their doctor appointments. And it starts in the moment they enroll and ends 15 months of the baby's life. And it's very cool because the member gets reminders of the doctor appointments, and also they get reminders of the rewards they can get once they make it to the appointments. And they receive weekly education. And some of the examples of those, what we call the Healthy First Steps, will be the prenatal appointments, postpartum, and then once the baby is born, those pediatric visits, the lead testing, etc. So once the member is engaged, the next strategy is that support and empowerment. So as long as the incoming data is showing us that the member is receiving the appropriate care, they're clinically stable, they don't have any open needs for case management, they will receive education and they will not be case managed. Now, should that data that we receive show that the member may have additional medical needs, behavioral, social needs, or is not consistently accessing their prenatal care, then we will get an alert and that member will be referred to our maternal coordinator. And that maternal coordinator, based on the member, makes a decision if the member is referred to our maternal nurse or our community health worker. So when the member needs are more in the complex, more complex or more in the clinical part of the complexity, so more chronic conditions, I would say, it goes into the registered nurse. And the registered nurse does a first, second, third, and postpartum assessment. They assess for those needs that occur outside of a healthy pregnancy, like the 17P McKenna, which is the progesterone, help with hyperemesis, which is when moms get very nauseous and vomiting a lot. We provide support on that too, of course, and any other needs. But the nurse also works on addressing those social determinants of health needs, provides education and assess for behavioral health needs and substance use disorder, and connects the moms with those resources. Now, when the members' needs are more into the social determinants of health spectrum, then they get assigned to a community health worker. And the community health worker is trained to engage with a member, talks about the importance of timely and consistent care, will help the member find a provider if the member doesn't have it, etc. And the RN will do the same type of work too. And of course, look at the social determinants of health and connects the member with those resources. One thing that I do want to point out here is that the maternal nurse does her work telephonically, but our community health workers do home visits too. And that's based on the needs of the mom or the circumstances. So it's in a need-based cases. So part of that support and empowerment is how do we provide support? And so I wanted to share with you some of the strategies we have in place, but I'm going to go fast on this because although social determinants of health is my other passion, I don't want to bore you, I'm sorry, that's the word, with everything we do on this side. But we do have a housing navigator that will work with our members, so with our pregnant members, to obtain housing if they're homeless, or to maintain housing if they're having issues. So we want to make sure that we're avoiding evictions. We have a food access specialist. She works with our moms and our clinical team to make sure that our moms are accessing the food that they need. And we have our internal resources, the same for housing, to make sure that our moms stay housed. But for food access, we have our moms meals that we can send to our pregnant members to ensure they're receiving nutrition if they're having any barriers to food that we cannot address in any other way. Then, of course, we talk with our members about our value-added benefits for transportation, so that they know that not only they get the support to go to their clinical care, but they get the support to go to church if they need to go and buy food if they need to, I don't know, the pharmacy, or even to go to work. And then we have our education and employment specialist, Christina, who is very focused on supporting our members, number one, to access their value-added benefit that we have for education. So if the member wants to finish the GED, wants to go to coding classes, or anything else that they need, Christina will work with them at the one-to-one level to access the benefits and help them plan and connect them also to, for example, workforce centers to improve income or get a job or whatever else that they need. Now, that part of that empowerment is not only providing the resources, but also providing education. But I'm already talking too much, so I'm going to go over this. Is the regular education that I believe everyone provides. So you have it. I don't want to miss more time on this part. I'm just going to keep moving forward. So the other part is what work that we do with provider engagement. And really, this is something that I'm not very knowledgeable about, but I'm learning. So what I do know is that we have our provider engagement team who seeks those collaborative partnerships with network providers and practitioners with a focus on improving prenatal and postpartum care, and also improving those risk assessment and the promotion of healthy behaviors as part of those shared saving agreements and quality incentives. So again, this is not my area, but some examples of that that I also think they fall under value-based care or value-based contracting are the maternity episodes of care, which I didn't know what it was, and I learned, and I do hope you don't have a lot of questions, but if you do, I do my best to answer. The Oprah incentives, I already mentioned that. Then the OPCP PCPI, which in regular words means incentives to providers that close gaps in care. And then we have a value-based contract and great relationship with New Birth Company. Another strategy, I'm already in 13 minutes. Another strategy, and this I'm very excited about, is what we do with our community partners. So we are working and have been working forever in developing initiatives that aim to reduce those health disparities and ensure that our programs meet the diverse needs and community, especially our multicultural population. So some of the things that we have in place is, one is that we're part of the IRIS network. And if you don't know what IRIS is, I'll be happy to tell you once I'm done. But we use IRIS to connect our members to maternal and child services in Wyandotte, Johnson, and Sedgwick County. And then we use Bertha all around the state of Kansas to connect our members to any other resources they may need, like the social determinants of health. Now, we are working on establishing innovative pilot projects with various community-based programs and providers to have a higher or more significant impact on the outcomes of our pregnant moms. So we are excited to share that one of those partnerships is in Sedgwick and is a maternal community health worker program. And we are doing that in partnership with the Kansas Medical Research Institute. And I'm thinking if everything goes right, we should be launching next month. We are also working very closely with Cradle KC, I'm sorry. They are launching a universal home visiting program, and we are looking in supporting that program in 2022. And what you see down there at the end is some of the 100,000 meetings that we are part of. I'm just going to keep moving forward. Okay, this is another thing that is very exciting. So the beginning of 2020, we developed this maternal dashboard, and I don't know if you can see it right, but the map on the top that you see right there is Wyandotte. The map in the bottom is Sedgwick. And when you look on the side, you can see the metric, and then the delivery year, and then the ethnicity. So what we can do is change the metric. So the metric that is right now that you can see is our low birth weight proportion. We can change that to neonatal ICU admissions, to maternal death, or to infant death. And we can change the year, and then we can also change the ethnicity. And that helps us have a visual of where do we see at the zip code level those more profound disparities. So we have used this dashboard to help us inform where is that we need to be more strategic or be more intentional at developing relationships in community to support our moms. And I'm almost done, and this part is super boring, but so our program, how is our program evaluated, or who is monitoring our program? We have like a two-layer, or better say, two bodies who oversee our maternal program. So our national team provides the components of the program, and that's all the risk stratification, and then provide us with the reports of, you know, the low risk, high risk members and all of that. And then our Kansas maternal leadership team then looks at our performance against state compliance, looks at quality and affordability goals. And then a lot of these partnerships that I mentioned before come from this local team that likes to brainstorm about how can we do things better to improve the outcomes of our moms and babies. And to close, I have two stories, but I know I have talked too much already, so I'm just going to tell you one story. This is a mom who delivered a triple set of micropremies, so 3 very small, tiny babies, and she already had 3 babies at home. And because the babies came way too early, she had no supplies at home. On top of that, she was having issues with her partner and was very overwhelmed. And the rides from home to where the babies were was very long and was creating an economic, strength. It was very hard because she was paying a lot of gas. So the CHW met with the mom. She helped the mom obtaining the baby supplies. So they got the diapers, the car seats, the 3 car seats, and the safe sleep space for those babies. Then she was connected with behavioral health support. She received education on the mileage reimbursement. And she also was enrolling the home delivery meals to make her life a little bit easy. And currently our CHW was working with the pediatrician office to get the baby formula, the gel mix, which is to thicken the baby formula. So as today we know that 2 of the 3 babies had been discharged home and the mom is doing well. And we are hoping that the 3rd baby will make it home very soon. And that is the end of my presentation.
Lucia, thank you very much for your testimony. Committee members, we have questions of Senator Petty.
So I didn't want to leave out Lucia because she covered so much. So Lucia, I really appreciate all the information you provided us because United Healthcare is doing a lot with their Well Mothers program. You showed us the tracking. I'm just curious as to you're using how you said this tracking, this dashboard has just been in place how long?
We started at the beginning of 2020. So we started talking about the dashboard at the end of 2019, and then we had it at the beginning of 2020.
And we don't have the metrics for it. At least I don't see it. So like when we're looking at this, is the dark higher need?
That's right. Yes, and I don't know. I know there is many things that I cannot share because it's member information, but it's really, not that it's great, but it's very informative because when you're looking at the map, first I change and I look at it frequently enough, and then I can change the race and the years, and I can see the changes on outcomes on those pregnancies, and you can see exactly the zip codes where you have higher incidence sometimes for white moms, where are they, and then you can see a little bit more of where is affecting more of the Black mothers, and then where are the Latinos, for example. I don't know if I'm answering your questions, but that's kind of what it looks like.
Right. I'm from Wyandotte County, so I'm looking at the Wyandotte County one, so I understand. So are you using this then to see, to comparison from year to year to see if you're actually being able to impact those higher risks, usually, with probably Black or Latino mothers?
Yes. So I have not been looking through those lenses yet, but I know we will. I've been using this map. We have been using this to help us think of what are the strategies, of what are the partners, and also who are the moms that we need to work with harder, or closer. Does that make sense? So what you are suggesting is actually a great thing to do, and that's something that I will bring back to the team, looking year after year and see what changes do we see. But right now, I'm using it more. We are using it more to help us, what is the word? Reflect on what we see and create strategies that address those disparities.
Thank you.
Lucia, we do have a couple more questions.
Sure.
First from Representative Lynn and then Representative Ballard.
Okay.
Thank you, Mr. Chair. This could probably be for any of the providers, but I'm wondering if you have any measurable data on the outcomes. For example, the number of participants. You were talking about the low birth weight that was talked about earlier. How successful are you in your outreach to those participants? Do you have any measurable? How are you able to evaluate the success of this program?
Okay, I go first, and that's a painful question. So I know that some of the data we have shows that we have a great impact. For example, on the Healthy First Steps Rewards program, based on what the national team reports to us, it has great impact in increasing the mothers' attendance to their appointments and decrease ER visits. Now, I have not seen if the end result of that is a good birth outcome. Does that make sense? So I know it's helping at some level on that provider member continuity of care, but I don't know if it's making that a positive birth outcome. So I don't have that data. And in general, I don't have right now. I think it's because I'm also kind of new to the program, and a lot of this data is also managed by our national team. I don't have numbers, specifics of those, of if all the work we're doing is leading to a decrease or an increase or things like that, which I think sadly is what happens in general on the healthcare system, that we're all trying to figure it out. Is all the work that we do, what is the true impact? but I will be digging deeper on this. I know our team wants to know what actually is more useful or not, but I will let my colleagues and the other MCOs, they may have a better answer than me.
This is Dr. Nshawat from Aetna. As I shared in my presentation, we're tracking the number of members or expecting mothers in care management, and also tracking the level of care, whether it's intensive, supportive, or population health. But mostly from a quality perspective, we're just looking at currently the number of prenatal checkups and postpartum checkups within 7 to 84 days. And we have noticed, as I mentioned in my presentation, 2.5% increase in our timeliness of the visits and postpartum visits. We also track the well child visits during the infant's first 15 months of life. And we've noticed a 5% increase since the implementation of the program just in the first quarter. I have not gotten my second quarter results, but we definitely, moving forward, we're going to be tracking the NICU admissions, the healthy deliveries, member satisfaction. There's a lot of metrics that we will continue to monitor down the road, but for now, these are the numbers that I shared with you today that we are able to track and report on.
Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chairman. I will follow up on that. And my question is from Lucia, but thank you so very much. You were giving us the scenario about the individual that had the 3 babies and what you were doing. I think if I heard correctly, you came up with the idea in 2019. It wasn't implemented until 2020, which, depending on when it was, it hasn't really been in effect a year or barely. So it's kind of difficult to get the results for such a short period of time. But once you indicated, I think that there were 3 babies, 2 went home. You're working on getting the 3rd one in order to go home. Is there planned follow-up once the 3rd baby is home? What's the plan for that? Because, somebody with 3 babies, I mean, you hear people cry and pray with 1, but when there's 3, how do you really plan to assist in that respect? Because I think that would answer part of Representative Lynn's question about the outcome as we go along.
Right. And I don't provide direct care to these members, so I don't know if I'm going to give you the right answer, but I do know that we follow our moms postpartum, and we follow our babies, until forever. I mean, they're our members. And so this community health worker, in this case, will continue to work with the mom to address all the mom's needs. And once she, and I don't remember exactly the day, the month, but at one point they fall off the pregnancy team, but they move into the whole person care team, where they continue to get support from community health workers and care coordination. So this mom would probably be with us for a long time until we think, or she thinks, that she has the resources she has in place to take care of her babies and the rest of her family. So I don't know if I answered that question, but
yes, you really did. Thank you so much. And actually, this whole 3-part was just really interesting of what happens, and what that really says is that you're tracking these people, these patients closely and everything. So that really sounds positive, because I think that's something we've been looking at wanting to do. So thank you very much.
My pleasure. Thank you for asking.
Lucia, thank you very much for your presentation, and thank you to the MCOs for answering questions. And I do not see any further questions from any members on the committee, so we will get ready to move to the next conferees. But before we do, committee members, if you are, for some reason, are not going to be here tomorrow, be sure to get with Sky to get your voucher signed. So if you're not going to be here tomorrow, be sure to get with Sky. So next up for presentations, these are going to be by providers and organizations. The first conferee is Tara Stroda, Coordinator for Fourth Trimester Initiative. Tara, welcome to the committee.
Thank you.
And just a reminder for our conferees, we have about an hour left. We do have your testimony in front of us, so a summarization of your testimony would be appreciated. So thank you.
Consider it done. My name is Tara Stroda, and I've been caring for women and families as a certified nurse midwife for 18 years. I'm also now the maternal QI coordinator for the Kansas Perinatal Quality Collaborative. KPQC was created to make Kansas the best place to birth, be born, and to raise a family. We implement and support efforts intended to strengthen perinatal systems of care for mothers and infants with the intention to create a culture of safety. By identifying adverse perinatal outcomes in Kansas, we then gather necessary stakeholders to collaborate on a solution and coordinate efforts to resolve the problem. From the vantage place of both my roles, both at the bedside and at the leadership table, I implore you to evaluate the current maternal health crisis in our state, to review the outdated, disconnected models of care, and to make necessary changes immediately to improve the outcomes of women and infants in our state. To the committee members, the data is clear in our state. We have a multi-tiered maternal health crisis at hand. As part of the Kansas Maternal Mortality Committee, which investigates pregnancy-related deaths and near misses, we found an astonishing 92% of the pregnancy-related deaths in our state to be preventable. Furthermore, we found that the care being provided to Kansas women is a suboptimal model with suboptimal financial and resource support, which is causing suboptimal health and social outcomes. All of this and the pandemic reports on short-sighted look are showing worse. While at first glance of the data, providers looked at each other in dismay, the next step was to resolve to want better. We wanted better for our patients and for the state. So KPQC jumped in, joined forces with maternal stakeholders across the state, and we intend to combat this horrific moment. Today, we come before you to ask you to join our team, the team that alters the life course and saves the lives of numerous women and infants in our state. If at first you want data, we've got it. So much data, in fact, that the medical associations tied to maternal health in Kansas, including ACOG, ACNM, AWAN, and others, along with the Kansas Hospital Association, KDHE, March of Dimes, Wichita Birth Justice, and many patient advocate groups have combed through it themselves and have tired of talking. They want change. However, it's only fair to pull out just a few pieces of our written testimonies where the extensive problem is outlined. We want to demonstrate a need to your committee today. Various Kansas data sets were in fact reviewed, including those gathered from Kansas Medicaid, Kansas MMRC, KDHE Vital Statistics, which is both birth and death certificates, and PRAMS data, which all demonstrated an alarming trend. Childbearing women are in fact in trouble. Specifically, and I think this is the data you just asked our MCO partners about, we now know that Medicaid patients are often those with the highest needs, yet the worst outcomes. Medicaid-eligible women experience more postpartum depressive symptoms following a recent live birth, an increase in the rate of cesarean deliveries among low-risk first births, increased rates of those who smoke during pregnancy, increased rates of difficulty understanding health information from providers, and decreased rate who are screened for pregnancy intention as part of preconception visits. Moreover, maternal health data shows that women are entering pregnancy with more chronic disease, like obesity, hypertension, and diabetes that require higher acuity care to prevent adverse outcomes. In addition, women are not achieving the adequate health care necessary to prevent these outcomes once they are pregnant. The model of care is antiquated. Significant racial disparities in care exist across our state, and horrifically, pregnant and postpartum women are dying at an alarming rate in Kansas because of it. Furthermore, the postpartum period has demonstrated to be, in Kansas, where we are losing the battle of improving maternal health at record speed. Postpartum complications, racial bias in care provision, access to screenings and adequate care, and lack of Medicaid coverage after 6 weeks post-birth have all been identified in the demise of Kansas women. Those women are our friends, our family, our colleagues, and our neighbors. This is no longer someone else's problem. It is our people, and the sickening data has become our call to action. My colleague Elizabeth Lewis from the Kansas March of Dimes will drill down on specific outcomes in just a moment, but I want to share with you a bit more pieces of our investigation to shed light on the necessary action. For over 2 decades, Medicaid reimbursement for the care in pregnancy, birth, and the postpartum period through just 6 weeks post-birth has remained unchanged. This is our patients are more medically complex and require a team with individualized treatment plans. Yet, Medicaid reimburses providers the same amount they have for over 25 years, $1,326.89. For all the medical care for pregnancy, vaginal birth, and the postpartum period. However, in contrast, Medicaid pays $1,500 for a 10-minute procedure called an endometrial ablation, done for heavy periods. This fee structure must change. Moreover, providers and systems must embrace care coordination and participate in patient safety bundles for outcomes improvement as part of that reimbursement structure. I have great news for you, committee members. We know how to do this. We know so much more about how to care for women in the perinatal period than we ever have before. We have excellent healthcare workers in our state and advocacy groups already doing the work. We are paired up at the local level, statewide, and in combination with best practice models across the country. We know exactly how to make Kansas women healthier, which provides a healthier Kansas baby to our beloved state. We can fix this. Our plea to you is for immediate response and action on behalf of Kansas women. So we have with us today specific examples of the problem and why the current Kansas model is failing. We want to share with you what we know can be done to improve and a call to action for your committee to begin to make an impact. That said, I'd like to introduce you to a hardworking advocate, mother-to-be, and trusted colleague, Elizabeth Lewis, Director of Maternal Infant Health for Kansas March of Dimes.
Chairman Hildebrand and members of the committee, my name is Elizabeth Lewis, and I'm the Director of Maternal and Infant Initiatives with the March of Dimes for the state of Kansas. March of Dimes and I appreciate this opportunity to discuss the maternal health crisis in Kansas. Medicaid is the largest payer for maternity care in the United States and in Kansas, and as of 2019, they covered about 1/3 of births in Kansas. These programs have an important role to play in improving maternal and perinatal outcomes. I'm going to lay out just 4 problems. You have my written testimony and my slides, but I'm going to lay out 4 problems with solutions in our state that can have drastic and profound influence on the outcomes for childbearing women, infants, and children in our state. First, there is a maternal health equity crisis in the state of Kansas, which has only intensified during the current pandemic. The problem is women, children, and families in Kansas need us now more than ever. Many structural, systemic, and environmental factors influence the health of moms and babies, especially for Black women and American Indian and Alaskan Native people. When adjusting for factors such as access to maternity care, financial stability, and health insurance status, these disparities continue to persist. The preterm birth rate for African American women in the state of Kansas was 51% higher than the rate for all other women. And according to the Kansas Maternal Mortality Report, while African American women accounted for 7.1% of the births in the state of Kansas, they accounted for 14% of the deaths. If you are born Black in the state of Kansas, you are more than twice as likely to not celebrate your first birthday. These disparities are persistent and preventable. The solution is managed care organizations in Kansas need to take immediate and decisive action to dismantle racism and address unequal treatment. We must engage in healthcare system reform, including educating providers on implicit racial bias to better serve our highest risk populations, empower communities through inclusion, education, social activism, and advocacy, and advocating work to change social and economic conditions, such as poverty, unemployment, low wage, housing, education, as well as underlying health inequities. And managed care organizations need to work with doulas, home visitors, and maternal community health workers throughout the state to make reimbursement attainable and sustainable. Increased access to doula care is one tool that can help improve outcomes and reduce higher rates of maternal morbidity and mortality among women of color in the United States. 2, prematurity or delivering before 37 weeks of pregnancy is the leading cause of newborn death and disability among infants. The problem is, at a time when medical knowledge is presumably at its highest, preterm birth in the state of Kansas has been rising for years. And according to the latest data from the Kansas Department of Health, 10.1% of all births in the state of Kansas and 11.9% of births to women on Medicaid in the state of Kansas delivered prematurely. This is higher than the U.S. Department of Health and Human Services Healthy People 2030 goal of 9.4 and March of Dimes goal of 8.1%. Moreover, premature birth and its complications were the largest contributor to infant death in 2019. With our state infant mortality rate at 5.3 per 1,000 live births and 7.2 per 1,000 live births for families on Medicaid, it is in the same year. In addition to the human toll, the societal cost of premature birth, last measured in Kansas in 2016, was more than $193 million, with approximately $56,000 per preterm birth. Premature birth has a major impact on society overall and on business in particular. Employers pay as much as 12 times more for healthcare costs for babies who are born premature or low birth weight, as compared with babies born without these complications. We all benefit from solving this problem. March of Dimes has partnered with Kansas Department of Health and Environment we partnered 7 years ago to create the Kansas Perinatal Community Collaborative. Evidence of this program's success demonstrates that true wraparound services like education, clinical care, language supports, maternity navigation, home visiting, community health workers, doulas, lactation support, and true integrated mental health screening, treatment, and referral. We know that these true wraparound services have demonstrated real quality improvement in our state in areas where these programs were enacted. Wraparound services need to be covered in a way that makes care teams the normal and sustainable model in pregnancy and postpartum care. These services have been proven to make a difference in maternal and infant health outcomes. The third problem, access to quality maternity care, while being a critical component of maternal health and positive birth outcomes, we are not providing this equally in Kansas, and maternity care deserts are affecting tens of thousands of women in our state. In Kansas, 102 of 105 counties have been ranked as a primary health care shortage. Kansas ranked 41st out of 50 states for health care with a quality ranking of 48. In addition to 31st in access and 35th in public health, based on the U.S. News and World Report rankings. Kansas has 45 counties classified as maternity care deserts, with 35,000 women aged 15 to 44 lacking essential services, especially in rural communities. Additionally, there are 24 counties with low access to maternity care, representing an additional 58,000 women. The solution is we need to implement perinatal regionalization, a strategy to improve both maternal and neonatal outcomes. We need to eliminate outdated practice restrictions for advanced practice nurses. We need to enhance reimbursement for certified nurse midwives, group prenatal care, and prenatal mental health. The fourth problem, psychosocial factors like chronic stress, lack of social support, maternal mental health conditions increase the risk of preterm birth, substance use disorder, and maternal mortality. The problem is in Kansas in 2019, 20.9% of mothers, 1 in 5, reported depression during pregnancy. And despite available screening tools, many perinatal mood and anxiety disorders went undiagnosed and untreated. Of those diagnosed, only about 50% of prenatal women with depression will receive any treatment. Women living in poverty and women of color are less likely to experience are more likely to experience maternal mental health conditions and less likely to get help for those conditions. And this is due to lack of access to health care, including culturally appropriate mental health care, culturally and racist biased healthcare systems, more barriers to care, such as lack of transportation, childcare, or fear of child protective services or immigration agencies becoming involved. Rates of prenatal depression have been shown to be increased up to 50% of Rates of prenatal depression of up to 50% have been documented in African American women. The total estimated societal cost of untreated prenatal mood and anxiety disorders in the United States is $14.2 billion for all births in 2017. And when following a mother-child pair from pregnancy through 5 years postpartum, an average of $32,000 for every mother-child pair, pair affected but not treated, with most of the cost borne by employers and healthcare payers. The solution is we need to extend postpartum Medicaid coverage permanently. And we need to ensure that screening for mental health conditions, both during pregnancy and in the postpartum period, is completed, and that positive screens are followed up with timely and effective services. Mental health professionals should be co-located within settings where screenings are being performed to provide immediate evaluation and diagnosis and treatment of mothers with positive screening results. When mental health conditions are identified in the obstetrical setting, providers and insurers should collaborate to ensure continuity of postpartum care both in the pediatric and adult health treatment settings, as these settings become more common points of contact after pregnancy ends. This builds on the American College of Obstetrics and Gynecology's recommendation on optimizing postpartum care. I'd like to introduce my other colleagues who are going to... Yes.
I appreciate you guys taking the initiative to recognize your colleagues. That is the chair's directive. But you mentioned something in your testimony that kind of alarmed me.
Yeah.
And I want clarification on this.
Yep.
Managed care organizations in Kansas need to take immediate and decisive action to dismantle racism and address unequal treatment.
Yes.
What do you mean by that sentence?
I mean that 51% of women who are African American are delivering prematurely at a rate that is 51% higher than other women. And when you when you look at research studies that compare college-educated women, they're dying from maternal mortality at a higher rate in African American women compared to less than a high school diploma in Caucasian women. So what we're saying is that there is systemic racism that exists in our medical systems, and that needs to be addressed. And that's consistent with lots of research.
Let's back up just a little bit. Those numbers are in Kansas.
Yeah.
So that statistic is what you're saying, systematic racism.
Well, the
That needs to be
prematurity
addressed.
rates, the infant mortality rates, and the maternal mortality rates. And as far as birth outcomes are concerned in the state of Kansas, there are significant disparities for African American women.
Okay. I don't disagree with that, but to come in to a meeting and accuse MCOs of systematic racism or anybody else based off of data, not actions. Racism is action. And to say that is doing a very large disservice, and that terminology of racism is being thrown around way entirely too much. If you have information that they are doing this, we need to know this and correct it. But if you're just basing that assertion off of data and saying it has to be systematic racism causing this outcome, that is not accurate. And as long as I'm a chairperson, I would please refrain from using that again.
I'm more than happy to provide the committee with a multitude of research studies which reflect those statements.
I don't want research studies. I want, if you're going to accuse somebody of being racist, I want a specific instance of an MCO treating someone in a racist way. That way this committee can act on that, because there's no place for that type of action. And there is no place to be calling someone racist when they're not. There are two steps. If you cannot provide specific data on this, please, in the future, do not just call somebody systematic racist.
I appreciate your feedback.
Do you have specific instances?
I can provide more of a written response to that I don't have a specific example of racism. That's kind of the definition of systemic racism, which is built on the roots of systemic racism. I can show you, I can reference the historic redlining that occurred in Topeka and Kansas City that led to different exposures to particulates within different racial communities. That's what we're talking about when we're talking about systemic racism, is that historic perspective of racism that it predicates and affects women today.
No, that's not what we're talking about. You called somebody racist, and they're implementing systematic racism in the way they're doing their business in front of this committee.
I don't
If that is happening, we need to know specifics, not data, not historic redlining. Everybody here knows what historic redlining was and what happened. It was a bad thing. If that is happening today, we need to know so we can take corrective action. If not, I'm going to ask you, please refrain from any future things of saying stuff like that and accusing somebody of being a systematic racist based off of data points.
I'm saying that the systems experience systematic racism based on historical, racism and current data suggesting that despite when solving for other factors, there are still racial disparities that persist even when taking other cofactors outside of that.
Racial disparities is different than systematic racism. Systematic racism is an action, is hate. And if there are people that the state is paying to take care of our citizens that are actively engaging in that, we need to know the specifics so we can take corrective action. If that isn't happening and you're just basing that assertion off of data and historical information, I am going to ask you to please refrain from calling someone a systematic racist.
I didn't hear that.
So what my actual statement was is that managed care organizations need to take immediate and decisive action to dismantle racism and address unequal treatment. And by that, we are talking about implementing implicit bias trainings to medical providers and making sure that if you're receiving medical training in the state of Kansas, that you're receiving anti-bias training as well. Those are the types of factors that we're talking about when we're talking about dismantling racism. I don't want to take too much
Is that
time from
bias
my
going
other.
on now? Show us
Yes.
the evidence that that bias, whenever someone goes to training if someone is saying, treat this person differently in your medical profession, that's an issue. That's a problem. We need to solve it. But if we're just up here saying historically, that is what causes these type of outcomes, if you do not have data, or not data, but if you do not have specifics, do not use that again.
I understand what you're saying, and all I can do is provide research that supports the statements that I made.
Then in future, as long as I am sitting as a chairperson, if you present testimony calling someone a racist, an organization a racist, anybody else a racist, you will not be allowed to testify.
Thank you.
Thank you.
Mr. Chairman.
Representative Ballard.
Thank you. I think it's sometimes how we hear it. I'm looking at the sentence that Representative Landwehr was pointing it out to me when it said management. Would you read that one too? Because I'm not looking at it.
Managed care it's on the third page of her testimony at the bottom. Managed care organizations in Kansas need to take immediate and decisive action to dismantle racism and address unequal treatment. So I think, Representative Ballard, where the chairman's coming from is telling us that our MCOs in Kansas are racist and provide unequal treatment based on color.
But yet, when I heard that sentence, I did not see it as the MCOs were being accused of being racist. It was, if you are new and you started on Monday, a system is already established there, and there's research to show that it is. So that job would be to go in to see about that and to dismantle anything that was there. They were not being accused, it's a statement. So I think it's a matter of how you perceive it. But when I heard it, I didn't hear anyone being accused of being a racist. It's looking at the situation. And if you are in charge of it, then you have to look at it. And if your data shows that you have low birth rates and all of these things are happening, you have to oversee it. But it does not mean that the MCO, the way I saw it, was a racist. So I mean, I'm not disputing, I'm disputing what you're saying, but I'm not agreeing with how it came across. Because I just saw it as it was
I appreciate that, Representative Ballard.
It was a system. You but as a chair, you have that prerogative to do that.
Before you can dismantle something, it has to be there, has to be in place. There's no way to dismantle something if it was not there. So if you're going to dismantle, you're going to take it apart. You're going to change it. So that right there refers to, and that's what I took. So we have spent long enough on this topic. We wasted enough time, and I apologize, but I wanted to make sure that if that was happening with any of our MCOs, we had specifics, because that's not, has no place here. Racism has no place, and if that is happening, and if anybody has that, please show us specific cases and instances where that is happening. If it is not, please do not use those words. Mm-hmm. Moving to our next conferee is Kendra Wyatt, CEO and co-founder of New Birth Company. Kendra, welcome to the committee.
Hey, well, thank you for having me this afternoon, and thank you so much, Chairman and the committee, for holding time out for maternity. I promised myself I would come to you all and spend, in this case, a very short period of time trying to explain why a highly valued provider model like the birth center in Wyandotte County, which is the gist of what we're talking about here, had to dramatically close as of 7/1, and to propose some solutions, because we're in it to win it. So I want to thank Tara and the March of Dimes for setting the stage. I'll just reference a couple things because you do have my testimony in front of you. If you have this as just a reference, this is MACPAC. This is a bipartisan, nonpartisan commission that makes recommendations to Congress regarding funding of Medicaid. And I want to reference this because the very last page, guess what it talks about? It talks about midwives and birth centers. It says, hey, at the end of the 16 pages, we've got something in Kansas that truly is a Kansas homegrown solution, and that is midwife-led birth centers. So very quickly, and this is just a real tragedy that we were forced because of what Rebecca Williams will more broadly get into, a hard malpractice market. We had to dramatically close our Kansas City, Kansas birth center. And what we wanted you all to know, and this is gosh, we had what we needed in terms of a solution. We were in the right place. This is actually an example of the redlining historically in Wyandotte County. So we were in the right place. We were a HRSA site. That means that we had signed up to give care to anybody, no matter their ability to pay. And so that included some of our non-eligible moms in our community. And the number one thing we did right was that we provided immediate prenatal care. So in the history of New Birth Company and KCK, close to 900 pregnant women were able to be seen in their first trimester early, and most importantly, they were able to be referred. So as you hear about perinatal regionalization and adjusting risk from those MCOs, we were the providers being able to get that assessment and that referral done very quickly. And then ultimately, we did have 559 of these women gave birth in community. So these were women in Healthy Start zip codes who were able to give birth in their own neighborhoods and their own communities. Literally, these are these women who may not even have the ability to drive as new immigrants, but were able to walk to their prenatal visits. Most importantly at all, and I want to bring up, there was a clear difference in the 3 MCOs in terms of being focused on outcomes versus being focused on the bare minimum of NCQA measures. We want to be focused on outcomes in Kansas. And what we as providers are asking you all and KanCare to do is perhaps have a consistent set of measures that we all, MCOs and providers, professional providers as well as hospitals, as well as our obstetrician and perinatal colleagues and neonatologists can all work together. Because the reality is we work together as a team. Is what care providers do every single day. And we would like to see new models encourage that and acknowledge that is what we want to say. So real briefly, what were the contributing factors? Why did this good thing close in such dramatic fashion? Number one, the last remaining private malpractice company that was serving independently owned birth centers left the market. And so then, therefore, we are at the mercy of the stabilization fund. And the reality is there are 3 sentences in KSA 40 and KSA 65 that are missing the word maternity center. And as a result, we did not have access to the KanCare required facility malpractice, and therefore barely by the skin of our pants were able to keep our location in Johnson County open. Rebecca again is going to speak regarding we are entering a hard malpractice market that is not just about us. We are just the canary in the coal mine. We're talking about increases across the board. And I really just wanted to be here to speak on behalf of independent Medicaid providers, because we are the ones that show up. So these are people, we don't work for big hospitals because if you work for a big institution, you may not be allowed to come and say what you really think. We are the people that want to serve our neighborhoods, our communities, and live in our rural towns and keep our rural communities robust and alive. So number one, we got some work to do with malpractice, and we know exactly what we need to do. I'm kind of looking at Senator Gossage and hoping she might be able to help us out. And number two, this idea of malpractice or reimbursement continues to come up again and again. So CMS has updated its Medicare fee-for-service fee schedule, and it updated obstetric and midwife, nurse midwife reimbursement significantly for 2021. We're talking about a jump in nearly $700, $800. And so what this, I brought a big chart this time, what this does to us as nurse midwives in the state of Kansas, it essentially tells us if we believe in capitalism, we are fools to serve KanCare members. We should only be serving third-party insurance, and that's not right. We fundamentally believe every woman deserves an incredible birthday. It should not be based on her zip code or her ability to pay within the system we've designed today. We think we have enough capacity to be able to serve every woman. And at the end of the day, our model of care is one of resilience, and that pregnancy and birth is a life course, and that we can teach women and families to be more resilient and to view their pregnancy and birth as just that initial stepping stone in terms of having a strong family. So I'm going to let my colleagues continue to give you a little bit more information in their personal perspective. And then we were hoping that we'd still have some time after we were done to be able to answer your questions and, again, to be able to suggest solutions.
Kendra, if you don't mind.
Yeah.
Representative Landwehr has a question for
Yeah.
Can you get us copies of your charts? I don't see them in your testimony.
Yes.
Okay.
And Mr. Connor has them.
Oh, is that on that other form that's, okay, that's all right. And you can send it to us digital. I'm good with that. Thank you.
Yeah, he's got PowerPoints. Yes, yeah, and that's brand new. And I just want to reference so you can tie together what Tara said with what I'm saying, is that in Kansas, certified nurse midwives are still only paid 75% of the physician provider rate. And so that's why the number she references is a little bit higher than my number there. That is the only payer where we have that difference. Otherwise, certified nurse midwives have been recognized by the federal government as 100% providers, and all of the other third-party insurance plans follow suit. So this is the only place where we don't get paid for the same work, if you will.
And I'm stepping on my chairman's toes, and I apologize to him for that. Is that, so you're saying that all private insurance companies are paying you at this higher rate, but the MCOs aren't? Is this something that you're seeing in other states or just in Kansas?
Kansas is only one of a handful, I say maybe like 4. So it's the minority, not the majority. Where there's even a difference. And I do want to state, certified nurse midwives are different than the other classes of APRNs. They have always, because of the ACA law, they have always been considered 100% providers, whereas Medicare still considers family nurse practitioners, for example, at 75%.
On the Medicare side, not
Correct.
Medicaid. And when when you talk about these other states that are in the minority, are they also managed care companies, or are they all straight Medicaid? Or both? Combination?
Both.
Okay.
I mean, yeah, and that's again another assumption. We assume that the MCOs do something special with their reimbursement. All MCOs do is administrate the fee-for-service fee schedule. And so part of what we're asking to talk about today is let's mix it up. Let's do some other things, and maybe we don't have to worry so much about the fee-for-service. Maybe we can work together in teams towards an outcome.
Kendra, thank you.
I'll pass it on, yeah.
Okay, next we have Carla Morales, private citizen. Carla, welcome to the committee.
Thank you. My name is Carla Morales. I am a community health worker with Community Health Council of Wyandotte County. Dear community members, please consider that over 200 pregnant women deliver without documented prenatal care. Kansas taxpayers pay for hospitals and bed costs no matter how little care mom receives. This story describes the gap in services left by the closure of the Kansas City Birth Center. This is my personal story with a client of mine. My client was referred to me in order to find prenatal care. She resides in Olathe, Kansas, but due to low cost and ineligible to get insurance, she could not afford it. I did try to refer her to 2 separate clinics down in Wyandotte County, but she declined both clinics due to where she would be delivering locally. I did try, I spent half my morning looking on the web. I found 3 out of the 4 clinics that I called wanted $1,500 down payment or $1,500 upfront at the time of the visit or before the visit. Oh my gosh, excuse me, which she could not afford. The last clinic that I did call was New Birth Company, which only required $175 upfront for the first visit. Due to her not being able to speak English, I was there to provide her interpretations and get her appointment scheduled within a quick amount of time without her having to pay that amount of money. That is all. Thank you.
Carla, thank you very much for your testimony. And if all the conferees, if you guys don't mind sticking around afterwards, if we have any questions that pop up, we'll call on you if that's okay. Thank you.
Thank you. That is all?
That's
Thank
it.
you.
Thank you, Carla. Sorry. Next up, Rochelle Garcia. And if I butchered your first name, I apologize. I saw an L and apparently
It's okay.
I needed larger print instead of regular print.
I'm used to it. It happens all the time. You didn't say roach, so that was a good thing. My name is Roche. Just mother of 6, well, almost 6. But I've had 4 of my babies at a birth center. I've had 1 at a hospital. And all I want to say is that if you want to change a community, you start by acknowledging the strength and courage of its mothers. It's a big decision to have a baby at a birth center, all natural, unmedicated. Birth center shouldn't be about politics or money. It should be just life. You know, it's a choice that I think that moms should have. Giving birth is something that is God-given, and I think it should be, I wanted to ask that it's supported financially. And giving birth is a God-given right. Women deserve a say in how to deliver her baby, when to deliver her baby. Women's bodies are made to deliver babies, and we should be trusted. I trust my body, I trust my midwife, and I think that should be taken into consideration. Women are strong, we can do it. Deliveries don't have to be in hospitals. They can be at birth centers, they can be, if I wanted to have my baby under a tree, I should be able to do that, because it's, you know, it's something that we've been doing since the beginning of time. And I don't think it's something that should be taken away from us. And it broke my heart when I found out that New Birth Company closed, especially in Wyandotte County where I sat. A lot of moms depended on it and still do. So I just want to ask that you give us our choice back to have babies naturally in a birth center. Thank you.
Rochelle, thank you. Next, we have Rebecca Williams, Account Executive for Hub International Mid-America.
Thank you for
Welcome to the
allowing me.
committee. Sorry, I didn't have my button pushed.
Thank you for allowing me to be here today. I believe you have the letter that I wrote as my testimony, so I'll just recap. I'm an insurance agent. I've specialized in medical malpractice insurance for many, many years, 27 years with the same agency. I have insured new birth for a number of years, and we ran into a huge roadblock this last year, and I'm concerned that this is going to affect any nurse midwife in the state who is independent. The insurance companies don't want to insure nurse midwives in Kansas. New birth did not even have a single claim, and I went to many, many insurance companies. Nobody would insure them. We ended up placing their coverage in the Kansas availability plan, which, if you know anything about liability, that's the place of last resort. The state says that a nurse midwife has to carry liability coverage, so that was the only place we could go. Their premium was more than twice what they had paid in the past, which is one of the contributing factors as to why the facility in Wyandotte County had to close. My concern is this is going to continue to happen. If you're aware of what's happening with the Healthcare Stabilization Fund, they're requiring the primary insurance carriers to increase their limit from $200,000 to $500,000. So we're anticipating that many of the nurse midwives that we do insure, that their premium is going to double or more than double because that exposure is more than doubling. That's where the malpractice costs, or pardon me, the settlements normally occur is in that first $500,000 portion of the limit. So I just see that this is unfair to nurse midwives. It is a tragedy to the women in Kansas because having an independent birthing center or an independent nurse midwife available to deliver their babies, and let's face it, they do have a tendency to serve the most underserved of our community, they're going to become few and far between. They'll move out of state because they can't make a living when they're paying so much for liability insurance coverage. And the really difficult part to understand is if they're employed by a physician group or a hospital, I can get them cheap coverage all day long. It's the independent nurse midwives that are being discriminated against when it comes to the liability insurance. Thank you for having me.
Rebecca, thank you very much. Not seeing any questions for you. Our next conferee is Dr. Elizabeth Wickstrom, Midwest Maternal Fetal Medicine.
Thank you, Mr. Chairman. Can you hear me okay?
We can, thank you.
Wonderful. I appreciate the opportunity to speak with the Joint Committee today about this very essential topic. My credentials are already in my written testimony, so I'm not going to repeat them. I know we have very few minutes together today. What you've heard today from Elizabeth Lewis, Tara Stroda, and the rest of the conferees is that the state of Kansas is failing the women of Kansas, and particularly the mothers and the babies of Kansas. We see rates of maternal deaths, newborn deaths, maternal severe morbidity, illnesses related to pregnancy that are increasing rather than decreasing until they no longer resemble one of the most economically advantaged and medically developed countries in the nation. And we see inequity between races and between zip codes. That's remarkable and, in my opinion, unconscionable. So what can be done to make a difference now? There is a proven way to improve these statistics demonstrated decade by decade in our city and surrounding states in newborn outcomes and maternal outcomes. And the basis of this solution is ensuring access to a network of care providers for every mother and every baby in Kansas that is appropriate to their level of medical risk. So what does this network-based care look like? And I think you may have a giant visual aid about to appear in front of you that describes definitions of different levels of care providers. Low-risk mothers are cared for in their community by providers that are appropriately reimbursed to see them. Do you sense a theme here? Midwives in diverse settings freestanding birth centers alongside birth centers that are affiliated with hospitals, county health departments, or as part of a multi-specialty group, family physicians with obstetric training, OBGYNs, all of these can see low-risk mothers. And then there's a network that's pre-established so that if an increased risk situation arises, that low-risk provider already knows who they're going to call. And this is where I come in as a high-risk provider. That may just be a phone conversation. It may be an outpatient consultation. We see something unusual in this woman's history. She's risked out on her MCO risk screening. We saw something odd on her ultrasound. So that may be an outpatient consultation and an ultrasound in their high-risk provider office. Could be an inpatient transfer for antepartum care. Maybe she needs to stay a little while in a hospital and then come right back to her low-risk provider, back to her routine prenatal care and delivery planning. Or she may need inpatient maternal transfer for delivery, either because of something going on with the mother or something going on with the baby. I do want to emphasize that this idea of maternal care can refer to all aspects of prenatal care, delivery care, postpartum care, the entire spectrum of maternal care all fits together here. And we know that this regionalization of maternal care also improves newborn outcomes. Those definitions that are on the giant poster visual aid are from the American College of OBGYN and the Society of Maternal Fetal Medicine consensus statement. And in my provided testimony, they're found in Appendix 1, which is 3/4 of my written testimony. Most of it is not the Elizabeth Wickstrom words. It's the consensus statement appendix. So how are we going to know that this is working? So the March of Dimes, about every, 5 years, puts out a review that's called Toward Improving the Outcome of Pregnancy. And every time they put this out, I feel like they must feel like they're beating their heads against a brick wall. Every time they say, we've got to look at maternal mortality statistics in every state and not just look at the numbers, but let's do a root cause analysis to find out which of these maternal deaths are preventable. Multiple studies looking at those maternal deaths show that at least 30 to 40% of these deaths overall, pick a state, pick a multi-state region, those are preventable. And more of them are preventable among minority mothers. So then I looked at, what about just Kansas? The Kansas Department of Health and Environment's Maternal Mortality Review Committee looks at de-identified medical records to determine factors that contribute to deaths and identify public health and clinical interventions that can improve systems of care. Let me say that again. We here in Kansas have a whole group of people that's already doing this, and they look at these records and they don't even know who these women are. They don't know who's taking care of them. They don't know what hospital they went to, but they're trying to find out. This is a root cause analysis. What happened here and what on earth could have been done to keep this tragic outcome from happening? So we're looking at public health issues, clinical interventions. What could be done to improve the whole system here to make this better? So we know that these networks of care work, but they need funding. We know large portions of deaths are preventable, 30 to 40 if you look at the studies in general around the country. But when we look at this working committee from the Kansas Department of Health and Environment, they actually found that 90% of these deaths have at least some element of preventability through more consistent use of screening tools. Some of the things that have come up in this testimony today were the pregnancy risk tools that your MCOs talked about, the depression screening tools that were brought up by another conferee. If we talk about patient education and empowerment, if we talk about referral for treatment and making that treatment accessible, communication and collaboration between healthcare providers, Man, does that happen in my everyday life. The right hand doesn't know what the left hand is doing. I will tell you that's a fact. Community engagement and education and family planning education. So this whole wraparound services idea described by Ms. Lewis, all of these things can come together. We need the funding. We understand how to make this better. We need everyone in this room to have the same will to make it better. And then we need the wallet. Thank you for your time.
Thank you very much for your testimony, Dr. Elizabeth Wickstrom. Committee members, do we have any questions for any of the conferees that we had that talked? I do have one for Kendra. Kendra, if you could come up, please. Thank you, Kendra. And I apologize. You had said something, and I didn't catch where you tied it in, but it was missing one word. Was that a Kansas statute, or was it something with your insurance that it didn't cover because it was missing one word?
Yeah. In fact, I'm happy to provide this to Connor and we can pass it on. So the word maternity center, which is how KDHE refers to we birth centers. So in statute, it's referenced as a maternity center. There are, and this is from Rita Knoll, who's the chief counsel from the Healthcare Stabilization Fund. She has identified 3 places, one of which KSA 40-3401F, and then 2 places in KSA 65-504 and 523, that if we add maternity center back in, I can get my business back. That would give maternity centers equal access to the availability plan. As it exists today, only a defined healthcare provider can have access to that plan.
Okay,
And that is the emergency we're in.
So that leads me to another question. Were those changed? And when were they changed and why were they changed?
So if we go back a little bit further in time, maternity centers were actually part of child care facilities. If everybody digs into the history of maternity centers, they were created as essentially adoption centers. They go way back. And then it was a regulatory, administrative, executive decision to shovel the birth centers into healthcare facilities. We're okay with that. We were fine with that. We knew at that time, again, circa 2015, that we did not have equal access to the same, access to malpractice via the availability plan as our other colleagues. So even though that KanCare requirement in every insurance managed care requirement is that we as a facility carry $2 million of malpractice, they just left us out. So it's been missing this entire time. We've had the free market. As long as we had the free market, we were okay. There is no free market in the state of Kansas anymore.
Is there legislation written, proposed, or going to be?
As you all know, I'm happy to work with whomever to have access to a revisor to go pull this together. And I will tell you, we've got a real friend and colleague with Marvin Klebb, who is now the new chair of the Healthcare Stabilization Oversight Committee. And he is aware that this is a crisis. It was a crisis and does need, we are asking for immediate fix, not just on behalf of New Birth Company, but I plea on behalf of Yoder Birth Center. They're in a completely different and same situation as us.
Right, thank you. We do have a couple more questions. I don't know if they're for you or someone else. Senator Gossage.
Thank you, Mr. Chair, and Kendra, thank you for being here. We've had extensive conversations about this. I think it's just tragic. Yeah. You guys weren't able to stay open. And we've discussed the 434001, F, et cetera, and been looking at the potential of what legislation could we put together. So what you're saying is you're not included in the healthcare stabilization. and because of these two words were left out.
Just an absence. So there's three
Right.
places where maternity center just never was added, and at the time when we raised our hand, you know, people said, you can't, don't need it. So.
And then you also
Yeah.
said no access to something, and I missed those words.
What I was saying was this became an impetus because as long as we had access to the free market and there was a company who was willing to serve
Meaning
us.
You had a private liability
Correct.
company that would, but now that you don't.
Correct. Now we
Now it's a
only,
problem.
now we would only be able to access the availability fund, and it's this
Availability
language in the
fund.
statute that prevents, that dictates who has access. And even though the intentionality would be any type of healthcare facility, you would assume that would be the case, but the interpretation by the fund was, no, we need your specific type to be listed.
And are you aware in the healthcare stabilization and the availability fund, I assume are two of the same, is there a cost to the taxpayer for you guys to be able to use that as opposed to being able to use the independent?
As we are today, and I'm gonna pull forward something that Rebecca said. As we are today, the way that the Department of Insurance and the Healthcare Stabilization Fund are working, what we've caused is that the availability fund, which is only Kansas taxpayers, are the only entities who are funding the malpractice for us. So the intention is for the Healthcare Stabilization Fund to partner with the third-party market and encourage that partnership, not to be the only, as it was stated, the fund of last resort. It's truly meant to be for, very few cases, and our current reality is it is the only option. And we think there is more innovation that could and should be done. We don't think the only thing to be done is just to raise malpractice rates for providers. We think there are other items that we think could be taken up.
And so this would fall under the Department of Insurance.
I'm hopeful that's actually the case, is what we'd like to see, because the primary KSA 403401 would come somewhere else, but that is up to you all to tell us.
Thank you, Mr. Chair. Thank you, Kendra.
Thank you. Representative Rees has a question on WebEx. Representative?
Thank you, Mr. Chair. My question is also for Kendra. Kendra, Carla Morales, the community health worker, mentioned that she took a client from Olathe to the new birth company, KCK, and did interpreting for her. So that sparked a question for me. Do you provide trained or certified interpreters in your other clinic? Is it in Overland Park?
The dual situation that we had when we were in KCK, we were a HRSA site. And so that we then had an obligation to take anyone without ability to pay. We had Spanish-speaking staff on site and able to provide interpretation. Post July 1, now we're in a situation where we have no obligation, but have chosen to answer that call because we just don't think it's right that women don't get early prenatal care. So I can't attest that I've got hired staff to be able to do that. And I just have to point back to the lack of reimbursement for our business model. We can't afford to do that as a small business. We are not a federal entity and do not have any federal or state funds to support that.
And do you provide any information also in Spanish, like your brochures or intake paperwork or anything like that? Or any other languages?
We have a limited amount of our initial reference material and also on our website that we've interpreted into Spanish. And I would just say this is something we would love to do and love to be enabled to do, and would make all the sense in the world.
Okay.
Not at this time.
Thank you, Kendra. And Representative Landwehr, do you have a question?
Thank you, Mr. Chairman. I'm just wanting to get some clarification on this. It's my understanding that we might have MCOs that do valued-based contracts with some of you folks that provide bonus payments for outcomes. Would that be accurate? You can stand right, yeah, just sit right there. No, sit right there, you're fine.
So value-based, meaning incentivized for better outcomes, is that what you're addressing?
Mm-hmm.
Is that what it's addressing? So in order to qualify for that, you have to decide if, based on the model of care, so as a certified nurse midwife versus family nurse practitioner versus an OBGYN, apply and then grant. I would not be able to then achieve the $1,300 of reimbursement if I chose to participate in that enrollment. So it is a tricky model, is an easier way to say that.
Okay.
Not that it's a wrong model,
Right.
because the goal, in fact, I made notes feverishly about incentivized-based MCO. I will also tell you, by the way, that idea that we would all connect dots is the one thing I'm taking out of the door today. MCOs have great ideas, providers have great ideas, but we're not connected. And an outcomes-based incentive program would be amazing.
Okay, and your name is?
Tara Schroeder.
Okay.
Thank you.
All right. But my question was, and if the person wants to come up to me afterwards and tell me if they are one of those providers with an MCO that gets bonus payments, that's fine. I do understand that the midwife rate is the 25%, but it's also due to state regulations that's been in place since 1982. And KDHE wouldn't be opposed, and this, I just got this from KDHE, they wouldn't be opposed to revoking that 25%, but it would cost quite a bit, and they'd have to run numbers to see what that fiscal note would be, because it would apply to all mid-level practitioners. And off the top of my head, I can't tell you what that definition of all mid-levels would be, not just to midwives. Okay, you're looking at me kind of funny. You got something to say?
Is it okay if I come back up?
You can. Well, either that or just sit there with your mic. I don't care which. Just tell us who your name. It's good for the people that are online. That's why I'm asking your names, is to say who you are so that they can identify.
Yeah, this is Kendra Wyatt. I will only speak for what we have been told, is that we have been told historically it is possible to parse out the certified nurse midwives from the other types of providers because there is a Medicare definition that does recognize certified nurse midwives to receive 100%, and that some of the issues of not addressing this shortfall has to do with the small budget that exists regarding MMIS system changes. So not that it's impossible to do, more that there's a limited number of changes that the state chooses to make in its Medicaid managed care system, its fee system, on a yearly basis, and this hasn't been a priority. So that's my understanding, and I'll just clearly state, we are not advocating for family nurse practitioners or other practitioners per Medicare definitions to be reimbursed at 100%. We're just asking for equity per Medicare and gold standards.
Well, I guess I'm having a hard time understanding, because if you're getting reimbursed at 75 and you're asking for a 25% increase, that's 100%.
We are asking for 100% of the provider fee schedule. So
for private insurance.
No, for Medicaid. Kansas Medicaid reimbursement is the only payer in the state of Kansas that discriminates between the, quote, physician and nurse midwife payment. That is the only one. TRICARE is 100%. All third-party payers are 100%.
Yeah, but then but I think what happens is then you get into the difficulty of telling a PA or an APRN to not be given the 25% increase as midwives, so that you're carving out midwives probably isn't real realistic.
We carve nurse midwives out every single day because Medicare already carves them out. So we don't find that to be a difficult conversation to have with our colleagues.
Right. I think, Mr. Chairman, and I appreciate what you're wanting to do here, Eileen, and I know he wants to kind of keep us on a time schedule. It's probably a discussion, I think, for another day on this to look into it deeper, because I think there's just a lot of questions. You know, I want to visit with the provider that's doing the, what do we call that, the value-based contact, which provides bonus payments for outcomes. So I want to see what that's like. Thank you.
Okay. Thank you, committee and conferees. I would draw your attention, committee, to the written-only testimony. Angel Schmutz, Birth Center Director, Yoder Birth Center, Julian Van Loo, Director of the Unified Government Public Health Department. Now we will turn our attention to the discussion on hospital admission process for behavioral health. First conferee is Robin Chadwick, President of Ascension Via Christi Hospital, St. Joseph, and they are testifying virtually. Robin, are you with us?
I am. Can you hear me?
I can, thank you.
Okay. Mr. Chairman, committee members, thank you for your time today. As Mr. Chairman indicated, my name is Robin Chadwick. I'm the president of Ascension Via Christi St. Joseph in Wichita. And today I'm speaking about behavioral health specifically as related to the admission and the review process with the 3 MCOs. And I want to start out with some kind of the state of where we are right now and really highlight some wins over the past 12 months. Our behavioral health utilization review team, along with our managed care team, I think have worked very hard with the behavioral health components of all 3 MCOs, especially over the last 12 months. And things are better today than I would have said they were a year ago. So some specific wins to call out. Aetna, when a patient is admitted, as long as they meet the inpatient criteria, we most often are given 7 inpatient days to start with without having to provide clinical review for every single day. And once we get into that continued stay process, it becomes a bit more cumbersome. It can take 3 to 4 days to get approval for days, for additional days through that process. The electronic clinical review submission process that they use is pretty easy to work with for our team. And their medical director, who is specifically for behavioral health, has been very easy to work with. And so we appreciate that. With Sunflower, in the beginning, they typically will authorize 3, sometimes 4 inpatient days. They have their utilization review team has access to our electronic medical record. So that is a very simple process. Their UR nurses or case managers can go into the patient's medical record and see all of the documentation. And so that makes it very easy because they have access to that themselves. It makes working with them very simple. They also have, in the event there are questions or things that we need to discuss, they have a dedicated case manager and utilization review nurse that we work with. So that is very easy because the relationship is established. We know what they want, they know what we need to provide. And so that makes the communication very, very simple. Their medical director also is very easy to work with, which makes the peer review process much easier. With United Optum, we get a 13 days of inpatient stay authorized with no clinical review required, unless it's a patient who's admitted frequently. And if it's a frequently admitted patient, then the review process, the number of days authorized is not at 13. It can be something less than that. And there is more interaction in the early days. Their medical director also is very easy to work with, and there's a set 3-hour window for that peer review. And he is responsive and has, in fact, shared cell numbers with our psychiatry team, and they can leave messages. So that process works pretty well. One request that we would have is that for all 3 MCOs to have the same level of benefits for Medicaid recipients as outpatients. So we sometimes are able to avoid an inpatient admission and provide a lower level of care on an outpatient basis. So if a patient presents to our emergency department and we see that they're in a state of needing help, but they don't need inpatient care, we can help them through an outpatient program. We can do that with 2 of the MCOs. We cannot do that with the 3rd MCO. With United, we have to go straight to inpatient admission because they do not recognize or authorize the partial day program. And just to explain what I'm talking about, partial day hospital is 6 hours of group therapy in our clinic. And that group, that is a 5-day-a-week program. Intensive outpatient is 3 hours of group therapy, 3 days a week. So we like to use those levels of care with patients who would be safely cared for in that environment and thus avoid an inpatient admission. And conversely, sometimes we use that as a step down. We might be able to discharge a patient maybe just a little bit earlier if we can move them into a partial day hospital setting or an intensive outpatient setting. So a request would be that all 3 MCOs have that same level of benefit for patients on the outpatient side. So I wanted to highlight some areas of success and some things that I feel like have really been wins over the last 12 months. But we do still have some challenges. Over the last decade, I would say every insurance company, whether it's an MCO or a private commercial insurance company, seems to have moved to having insurance-based case managers. And I've been in many, many meetings over my career with the payer side who want to really promote utilization of the insurance-based case managers. But of my 30 years of healthcare, probably 23 or 4 were spent in case management. And honestly, I recently found one of those case managers, and it was actually with one of the MCOs, to be extremely helpful. But I will say that's the first time in my career that I found that insurance-based case manager to be extremely helpful. If we have a patient who requires long-term care placement and they're going to access Medicaid benefits to pay for that long-term care, the insurance payer case management, the insurance-based case managers don't help at all with that. They often will send us, they'll say, well, we have access to all of these resources, but yet when we get those resources, they tend to be very outdated. So I think there needs to be a review of how insurance-based case managers are used and what kinds of things they can do, and really evaluate the benefit of having that position. And if we're going to continue with that position, really to be able to work side by side with our inpatient team to figure out plans for those beneficiaries. Second challenge is authorization for a discharge plan. So if we have a patient that's going to go into a long-term care facility, it can take anywhere from 3 to 5 days for the long-term care facility to receive the authorization that, yes, that patient can move into that long-term care facility. Once the patient gets to that point that they need, and we have found a long-term care, the payment in the authorized days for the hospitals stop, but yet the receiving facility has not yet received the authorization. And so that process needs to be reviewed, and it would be so helpful if it could be facilitated in a much more timely manner. And then the second issue related to discharge plan, or really not for discharge plan and for authorization days, is when a patient has been in the hospital for a number of days beyond the initial authorized days and reaches that point that the determination is the patient needs to be in a long-term care facility. And that generally happens because they continue to be a threat to themselves or others, and or they are a self-care failure. So we have many patients with either dementia or significant mental health diagnoses, whether that's schizophrenia, psychosis, could be a variety of behavioral health diagnoses, or they simply cannot care for themselves in the community. At that point, the payers see that patient as custodial, and they no longer authorize days for inpatient care. But as you all are very well aware, hospitals are governed by CMS conditions of participation, and one of the criteria we have to meet is a safe discharge plan. So if a patient is a self-care failure or continues to be a threat to self or others, we cannot safely just send them out of the hospital and say, best wishes, hope things work out well. We must have a safe discharge plan for that patient. So I'm going to give you a very current example. We have a behavioral health length of stay meeting that meets every Monday and every Thursday, because believe me, our goal is to discharge patients as soon as we possibly can. On any given day at St. Joseph here in Wichita, we have 10 to 20 patients waiting in our emergency department to be admitted into one of our 100 beds for inpatient psychiatry. So we are not keeping patients any longer than we absolutely have to. And yet it feels like we are penalized for holding patients to keep them until there's a safe discharge plan. So the example I have shared is a current inpatient. So on the 20th, this patient was still stabilizing. And on the 20th, she had been here for about 30 days already. So this was a very treatment-resistant patient. Her condition, she came to us from a long-term care facility, and the long-term care facility was willing to take her back, but her condition had deteriorated, and it has taken us 60 plus days now to try to get her on a medication regimen that will allow her to be managed in a long-term care facility. So on the 20th, she's still stabilizing. She's loud. She's crying out loud, crying out, rapid speech, attention seeking. This goes on. 23rd, still stabilizing. 26th, still stabilizing. September 7th, still experiencing behaviors that are very disruptive. September the 13th, medications are still being adjusted to find the right medication that will work for this particular patient. September 20th, earlier this week, patient is still stabilizing. We have a facility that will accept this patient, but she is not medically safe to discharge. So today, her length of stay is 63 days. But the MCO denied payment after August the 10th, saying this patient was medically stable and we were only providing custodial care. We have situations like this nearly every week. We have a patient that falls into this particular category. Now, it happens with other payers as well, but this current example is a Kansas MCO beneficiary. So we still have this patient in our hospital today because she's not safe to discharge, and yet we have been denied payment since August the 10th. And so my my plea, I guess, to the committee, the Oversight Committee, is that this kind of situation really be looked at, because the financial burden for care for this patient falls squarely on the hospital when the patient does have a payer source. And we are providing medical care, we are changing medications, we are working hard to stabilize this patient. And trust me, we are not keeping patients longer than we need to, because as I said, today I've got 15 patients. At this moment, I've got about 15 patients in the ER that I would like to get admitted into the inpatient unit. So it's not that we keep patients longer than is necessary. This is a common challenge. So I don't want to bring up problems without talking about what solutions might also be. One of the challenges that we have is the limited number of mental health nursing homes in Kansas. I think at this point there are 10 licensed in the state of Kansas. That's not enough. We continue to see patients who need this level of care in our state, and it just is a challenge to find a facility that can accept and has capacity. I'm going to lobby once again for a regional state hospital in the Wichita area. I think a facility here with 25 to 40 beds would help so much. We always have patients here who are appropriate for state hospital, but we can't get them moved to the state hospital. And then I just want to end on a win. The certified community behavioral health clinics and the legislation that has been passed to create that level of clinic and that payment modality, I think will help our communities and will certainly help our community-based behavioral health clinics continue to stay alive. So with that, I'll end my testimony and stand for questions.
Robin, thank you very much. And we do have a question from Representative Landwehr.
Hello, Robin. It's good to see you again. I'm sorry you're not here in person, but I understand. Now, when you talk about another, because this has been discussed now for a couple of years, another regional behavioral health hospital, there is no intention, no desire to shut down any of our existing. This would be in addition to, is that correct?
Yes.
And it's also my understanding that there are stakeholders within the county and the city and surrounding areas of becoming partners somewhat financially into this, putting another facility in. Is that correct?
I think that's a possibility to be explored.
Okay. Because I think this all falls along the lines of when we've talked about the San Antonio project, and it doesn't mean that we copy San Antonio, but we emulate what we think fits into Kansas and into that region. And from the folks that I have visited with, is that hospital would have the capacity then to handle patients clear across the state on the southern end to the east to the west, which would relieve some of that pressure on our other facilities as well. And then that's my comment. And then my other question to you is, do you know if our juvenile behavioral health facility is full again, by chance? I know that's not an Ascension facility, but.
No, I know we had a patient waiting in the emergency department overnight to try to get into KVC in the Wichita facility, and we were hopeful that we would move that patient sometime today. So it really is day by day, whether they're full or not. Just like the day by day.
All right, so most of these patients are coming in through the ER, is that correct?
Yes, absolutely.
And how many, maybe it's not an exact number, but kind of a ballpark, say in the last 6 months to a year, have we had some of those ER staff assaulted because of the erratic behavior of some of these individuals? Not because they're criminals, they just act out and your staff aren't law enforcement.
We have someone assaulted probably, if we're just thinking emergency room, probably 2 to 3 times a week. And if we add in the inpatient units, and we have 100 beds, as I said, and then a psychiatric observation unit. Someone's assaulted, if you add in ER and inpatient, probably 5 times a week. That someone is hit, kicked, punched, shoved, hair pulled, bit. One of our most recent significant instances happened about 3 Sundays ago, and that nurse is still out on leave after suffering a very severe concussion.
Have you lost staff in the last year over this?
Yes.
All right, thank you. I could ask you tons of questions, and I appreciate that. I think it's, it's an ongoing discussion that we continue to have, and we'll keep saying it, Mr. Chairman, until we get it right.
All right, thank you, Robin. I see no further questions from any members of the committee. Next, we will turn our attention to Dr. William Gabriele, University of Kansas Medical Center.
Gabriele, yes, thank you.
Thank you, Doctor, for
my pleasure. Chairman Hildebrand, Co-Chair Landwehr, honorable representatives and senators. I have the honor and privilege to be chair of the Department of Psychiatry at the University of Kansas Medical Center. I've been chair now for 25 years. I'm also the clinical service chief for mental health at the University of Kansas Health System. The health, at least since the legislature created the separate existence in 1998, I was there when that change occurred. As chair, I provide over the academic missions of the department, as well as champion the needs of the faculty and trainees in our department. As clinical service chief, I have influence and oversight for the privileges and performance of the mental health providers, and I have the privilege to provide executive guidance for the clinical service. During these years, I've observed the evolution of managed care and the creation of KanCare in Kansas to meet the needs of Kansans. It's my privilege to be here today with my leadership partner, Ms. Lauren Lucht, who is the Executive Director of Mental and Behavioral Health for the health system. Lauren is the health system's Chief Operations Representative for mental health. Together, we have the privilege to represent the exceptional mental and behavioral health service line with about 600 employees at the University of Kansas Health System. I asked permission that she be able to share the presentation with me. We will give different parts of the presentation.
Doctor, that would be fine. Yeah, just as long as you don't read it, we'll have it in front of us. So yeah, she can share with you.
So when we discuss the MCOs and their relation to the hospital admissions process, I can best represent the perspective of the providers. The executive director, Lauren Lucht, I think, can best describe the unique business processes related to interaction with the MCOs, and we can both discuss the impact upon patient care and outcomes. I think it's important for me to say that we have a very good working relationship with the MCOs and the other providers, but we have a process in medicine of continuous performance improvement. And it's in that spirit that we make some suggestions today. Streamlining the process. Our organization has built a necessary infrastructure to work with each of the unique styles of the different payers, KanCare, commercial, out-of-state, VA, Medicare. We have learned the quirks of each, and we try to function within the framework of their processes. In fact, we have different individuals who have expertise dealing with each one to approach interactions. This is the crux of our first issue. Each MCO has their own process and procedure. We have to use varying computer systems and with varying feedback, timing, processing, and it's difficult. We have different staff members, as I mentioned, primarily responsible, and that's a personnel issue. Each quirk maximizes confusion, introduces error, and quite frankly, increases the risk of failed payment. What we ask is for standardization of this process. Other states do it. One step in this direction is the establishment of a clearinghouse approach to authorization and claims processing with a single portal for initial processing used by all providers and all payers. This can eliminate some duplication of effort and I believe reduce the chance of error. I'd like to now ask Ms. Lauren Luck to come and talk to the next point.
Doctor, would you mind standing just for, we have a quick question from Representative Landwehr on that point that you just made. If you'd stand, thank you.
Thank you, Mr. Chairman. When you talk about, the varying systems, et cetera, don't you have those same issues with private insurance as well as Medicare insurance?
We do, yes. It would be best if we could somehow organize the management of interaction with all of the payers in that way. But speaking specifically about the MCOs in Kansas, as opposed to, I understand, in Missouri, for example, there is a different set of processes.
There's a lot of things in Missouri we don't want to copy, so just so you know that. But I just don't want folks to think that, our MCOs are being unreasonable with their different procedures when you deal with that every day on the private sector as well as the multitude of Medicare plans that are out there as well.
Indeed.
Thank you.
Lauren, and if you wouldn't mind restating your name and who you're with for those that are listening in, please.
Absolutely. I'm Lauren Lecht. I'm the Executive Director of Mental and Behavioral Health for the University of Kansas Health System. So I have the privilege of leading the Mental and Behavioral Health Service line with Dr. Gabrielli. And I won't bore you by repeating any of what has already been said. We echo what Ascension Via Christi is saying in terms of we have no stake in lengthening the stay of any of our patients. Our EDs are full. We need to get those patients moved out of the EDs so they can initiate care and treatment as fast as possible. We know that leads to the best clinical outcome. And we run full every single day in our psychiatric hospitals. So for those of you who don't know, we at the University of Kansas Health, we have 2 freestanding psychiatric hospitals. One is an 84-bed acute child and adolescent psychiatric hospital in Overland Park, and the other is our adult facility, which is a 47-bed facility in Kansas City, Kansas. So we see things from both the peds perspective and the adult perspective, and so please feel free to ask any questions that you might have about the pediatric side. As I don't think that's been covered as much as the adult side. I absolutely echo how it feels that we are being almost penalized for needing a safe discharge plan. We have also had numerous times where we have patients that have no place will take them. They've turned into custodial care at the hospital, and the case managers that we partner with are wonderful humans at the insurance companies, but they're not actually able to help us get the patient placed. So for example, we had a patient that was with us for over 365 days. It took weekly conversations with that MCO, which we were happy to do, and we did that, and we did that, and we did that. It took our chief operating officer and chief nursing officer for the state, and Dr. Gabrielli and I to come down to KDADS to meet with Secretary Howard to help unstick where we were in between the MCOs and the next level of care that that patient needed to go to. So that's just sort of a real life example of how many, not just man hours, but years it can take to move one patient down. And think of how many other patients weren't able in the middle of a pandemic to get to an acute care bed because there wasn't a lower level of care willing to take that patient. And that's just heartbreaking to think of how many of our psychiatric facilities are running full. We have no place to send the patients when they discharge, especially those that are needing more long-term. I heard words earlier like, failure to thrive or be able to care for your own needs and needing that supportive behavioral health housing mechanism. So we would welcome an opportunity to have case managers that could really get in and partner. We know the list of the places. We have 1,000 beds. We send referral packets to every possible location. And then we hear back, we finally will escalate it to the MCO and they'll say, well, we're calling all of the administrators at the mental health nursing homes and we can't get callbacks either. And so then the option is to just let the patient take up an acute care bed during the middle of a pandemic. And we know that's not right for our patients. We know that doesn't lead to better health outcomes for them into the future. And so I think finding better ways to partner patients as they progress through the various levels of care. And so as we heard earlier, that includes intensive outpatient programming, partial hospitalization. You have to really be able to offer the full continuum, and you need to have some discretion to move people. The highest reimbursed days are the day of admission and the day of discharge. We have no incentive to want to keep patients for longer than that. We're doing it because it's unsafe to discharge them medically. And it's our responsibility to not discharge them until they are safe. And so we would echo the need for additional days to be authed on the front side of the admission so we can focus our energy on getting that patient better rather than what often feels like a battle for additional days to be approved. The other thing, and this is true of behavioral health reimbursement across the board, it is also true and does feel slightly more exaggerated with the MCOs, but the reimbursement level is so far away from being able to cover direct care costs. I believe it is really preventing additional hospitals from being able to open their doors. If we weren't part of a huge nonprofit organization willing to subsidize my service line, we wouldn't have this many psychiatric beds. And the for-profit psychiatric hospitals adjust their admission criteria to the point where they only take the patients that they can that will be very low cost to take care of, leaving places like us taking care of the most complex patients. One example would be if you need a heart transplant versus a liver transplant, those two things cost different amounts. But in the world of psych reimbursement, you could be so aggressive and so violent that you've attacked so many of my employees that I have to put 3 staff on you. I don't physically mean on you, but observing you to keep my other patients safe from you and to keep my staff safe from you. And that patient, we get reimbursed at the exact same level as a patient who didn't need a 1-to-1 or a 2-to-1, and definitely not a 3-to-1. So I think some sort of mechanism would be great. I do understand this is across the board, but I didn't think it would be, I could ride home with myself and not have shared that with this group because I know you're all trying to make this better. One other misconception is that we fill the beds to make the money, and I just want to make it really clear. It's cheaper for me if the beds are open than it is if a patient's in it, just to give you an understanding of how far off the direct care costs are compared to the reimbursement level. The other thing I'd like to mention is that as it relates to value-based reimbursement, Optum, for example, does have a platinum status, But you can lose your platinum status for things that are far outside your control. So for example, we do a lot of philanthropic work in behavioral health because we need it to keep the lights on. And we have a program where every patient who discharges from our adult facility leaves with their medication because we know that medication adherence is a major predictor of readmission. So when a patient can't afford their meds, I have philanthropic dollars I can tap into so that they leave with their meds. And when I found out from Optum that we had lost our platinum status and that one of the metrics that fed into this was that their records were showing that the patients discharging from our hospital that were MCO patients were not, in fact, filling their prescriptions. And I explained, no, they did. It just didn't come through as claims data. Can we share the information so that you guys can account for that information? And what we were told is the only way for that information to count towards our metrics to keep our platinum status, which we have lost, would be to force function the patient to fill it. And we all know that you can't fill something you can't afford. And so I would just ask this committee to continue to do what I think all of us in this room want to do, which is to keep the patient at the center of every decision we're making, because we won't solve this problem. Mental health is going to continue to grow. And now's the time to fix it before the system needs to quadruple. I think with that, I will end my testimony and open it up for questions. You guys have what we submitted already, so I won't waste your time.
Lauren, thank you for your testimony, and Dr. Gabrielli. Committee, do we have questions for either one? Representative Ballard.
Thank you. You made a statement that I have heard people say before. It's actually cheaper for me to have the bed empty than to have someone in it. Could you just expand on that a little bit more, why that is so, and people
Sure.
maybe does not realize it?
I would love to, and I'm so glad you asked that. So there's a whole bunch of costs behind just what the provider is providing to the patient in the room. There's all of this that in the world of psychiatry and inpatient psych, how you get a patient better is through labor, right? It's therapists, it's programming, it's physician expertise, it's medication, but it is mostly humans. It's human driven, and we all know that labor costs are incredibly expensive. So we strive, and our payers will say we have a very short length of stay compared to market. That's the one thing on our scorecard that looks really great. Our average length of stay is under 5 days. If you exclude those patients that are struggling with no backdoor placement. What we see is that when the patient is there and we have all of the FTEs we need to provide all of that programming, that is what's going to get them better. It'd be like you going to a medicine bed and needing a medical procedure, a CT, for example, to identify what is wrong. In psych, there's no CT that tells you what's wrong. We want to rule that out and make sure that there isn't an underlying medical condition. But we get people better through caring, treating providers. I'm a clinician by training. We run our programs with phenomenal clinicians. We run them to be 7-day-a-week programs. Patients admitting on a Saturday should have the same quality experience as a patient who admits on a Monday. The reason the for-profit hospitals have to license their psych beds as IMD beds is because they can't afford to have a physician on site 7 days a week. I think that's important to recognize. Is that really going to help us improve the mental wellness of Kansas by continuing to force function people into what I would consider to be substandard care? I would not want my relative sort of being tucked away on a Friday night and the doc to say, hey, I'll see you Monday, and no treatment to occur on that Saturday and Sunday. And in this case, the MCOs are paying the exact same amount to reimburse for a Saturday as they are for a Monday. So what would be fair for everybody would be for the reimbursement to at least get us a little closer to breaking even, like maybe 50% of the way there. We're not asking for break even. We're just asking to get a little bit closer to break even on those direct care costs. Because I think the other way I could see this going is people continuing to cut corners and not provide as intensive programming, not offer 7-day-a-week care, and that's not going to help reduce the burden of mental wellness on the healthcare system right now.
Thank you, Mr. Chairman.
And we do have a question from Representative Reese online. Representative?
Thank you, Mr. Chair. Lauren, this question is for you. You partially already answered it because I was just wondering what the average length of stay was. And you said it's under 5 days?
At Marillac, my average length of stay is 4.7 days. At Strawberry Hill, which is Marilac's the child facility, at Strawberry Hill, my length of stay is, if I exclude, so right now I have one patient who has been there for 77 days and another patient who has been there for over 10. That's actually a really good day for us. Usually we have up to 10 patients who have been there longer than 10 days due to either guardianship issues or not having a place to step down to. But when we pull those out and when we look at our MCO specifics, the average length of stay is 5.3 days.
And is detox included?
Detox is not one of the things that we offer at our freestanding psychiatric hospitals. That would be done on the medical unit.
Sure. And, you know, the days are intensive, correct? I mean, patients are being checked on about every 15 minutes or so, and they have to go to group.
You're right. At a very least, they're checked on every 15 minutes. More than 50% of our patients that admit to our Marillac campus require one-to-one observation upon admission, and that's because they're planning to hurt themselves or they're planning to hurt other people. We have an obligation to prevent them from hurting themselves or other patients while they're in the hospital. And to keep the other patients safe, I have to wrap lots of staff around the aggressive patients, not physically, but just to be that buffer to keep that patient from harming anyone else. As a mom.
Could also mean that you're adding staff to make up for person or the persons that are doing one-on-one.
Correct. I am calling staff in for overtime and callback pay because the number of precautions that come in is beyond what we have in the building to staff. And sometimes it's beyond what we have the ability to call in and can actually take beds offline, reduce our number of staffed beds.
And thank you for that description, because that really is a good picture of what goes on in patient. A lot of times people think that folks go into the psychiatric hospital and they sleep all day. Well, it could be that maybe that's what they need. But they're getting
Now, it would be a lot cheaper to let them sleep all day, but that wouldn't be the right thing for patient care. We actually spend a lot of the day trying to make sure that we lock their rooms during the day. It's a clinical decision whether they're going to go back into their bedrooms, because what is important, what's going to help them get better is going to the groups. Now, in collaboration with their physician, if we have a manic patient who hasn't slept, of course we want them to sleep, and our focus and our goal will be on sleep, and groups later will get through that immediate stabilization phase. But yes, how you get better in a psychiatric hospital is through human conversations, through therapy, through programming, through yoga, through exercise, through resiliency, psychoeducation, learning how to manage your medications, and of course, really great physician management.
Thank you so much for that description.
Okay. Thank you, Dr. Gabrielle and Lauren. Doctor, you have one last comment?
May I finish making my comments?
You sure can.
Thank you so much. Hold on. Ms. Lucht is amazing, isn't she? So I won't read the rest of it, but I want to talk to two things that are important to me. I have a PhD in psychology, a master's too. I have a postdoc in behavioral genetics. I have a residency in psychiatry and another in internal medicine. And I still practice both internal medicine, primary care, and psychiatry. It's a very unique experience in the world, I think. And one of the important things that's for me is where we place mental health in the continuum of care. I think it's important to know that we at the KU Medical Center have what I think is the best combined internal medicine and psychiatry training program in the nation. Certainly among the best, if not the best. Part of that is driven by the philosophy that mental health is health care. Mental health care is health care. Our patients aren't different from the others that you see in our hospital. I have 7 doctors working in the medical wards, helping to manage the behavioral issues of the patients. We continuously, in our primary care or med-psych clinic, focus on the whole person. This is an important distinction. We shouldn't have, I believe, a health insurance system that separates the two. There are lots of ways that patient issues really are both mental health and other comorbid medical conditions simultaneously, and they're not best managed if we try to partial that out. There are times when we lose reimbursement because some things are thought to be one more than the other. It's not a fun system to work in. Now, my expertise is not the insurance side of things, or even the operations as much as Lauren's, and she can tell you more about this topic. But I think it's important at least to think about the future that no longer requires MCOs that are carve-out companies that manage the mental health separately. The advantage in the 1980s, because of the runaway institutions that were milking the insurance companies dry for the worried well, those days are gone. We don't do that. We take care of people with real issues and real problems, and as Lauren said, we do it at a deficit. Final thought. It is a privilege for us to serve the people of Kansas in the way we do, and we're grateful for that privilege. Our goal, as I believe it is yours, is to make the process better. We welcome continued dialogue with the MCOs, which we work with every day, and the other entities as well. And I think together we can make a better world. If you have any questions for me, I'd be honored to take them. I want us to continue to do what is best for the people of Kansas, providing quality mental health care in an academic medical center, one of the best in our great state, that's committed to education of the next generation of doctors, as well as motivated to help push back the frontiers of knowledge and quality health care. Mr. Chairman.
Dr. Gabrielli, thank you. And I do not see any further questions for you. So again, thank you for your testimony. Committee, we will now hear from the MCOs. Dr. Will Barnes, Behavioral Health and Medical Director for Sunflower.
Mr. Chairman, this is Dr. Sandra Berg with United, and I believe I will be speaking on behalf of the MCOs.
Oh, okay. Well, Dr. Sandra, you're going to speak on behalf of all of them, correct?
Yes.
All right,
And
thank
then
you.
I believe if Dr. Warrens is on, Dr. Inchwat also can answer any questions specific to their MCOs. Thank you, Mr. Chairman and committee, for allowing us to present today on our processes for inpatient behavioral health care As you've heard, this is a really critical time for looking at the system and making sure that those vulnerable folks with mental health issues get the care and treatment that they need. What we'd like to do is walk you through the process that the MCOs follow for inpatient stays, and then ask any questions that you might have. So when a person admits to an inpatient psychiatric unit, we are given notification that that person has admitted, and we follow pretty much a 3 to 5 day authorization window for any of those admissions, as you heard from our provider partners. We do want to clarify that there is a difference between doing continued stay reviews and discharge planning. Some of our MCOs will be actively involved while the person is in the hospital working on those discharge plans. And then other times they will do concurrent reviews to make sure that the person continues to meet the need for medical necessity. We do expect that discharge planning begins on day one, and it progresses through this stay to help that person transition back to the community and back to a level of care where they can function on their own again. We feel like discharge planning is very critical to ensure safety and to make sure that person is successful when they do move back. Another aspect of the process that we wanted to cover was to identify and clarify what we use for medical necessity. All of the 3 MCOs use a nationally accepted standardized tool when we look at determinations for continued stay and for admissions. All of our clinicians must pass competencies in those tools, and they also have to meet a threshold of inter-rater reliability to continue to use those tools. We also make sure that our medical necessity process includes looking at the criteria, having peer-to-peer consultations, and gathering more information as we review those cases. In Kansas, Medicaid allows for observation days, which can be billed for up to 72 hours. During that time, there is no prior approval that is needed. If the person does stay for longer than 72 hours, the entire stay reverts back to the payment methodology for a typical inpatient stay. I wanted to point that out because sometimes there is opportunity for use of observation days, and I think many of our partners are doing that when the person doesn't quite meet the medical necessity but does need those observations to get them where they need to be. One of the barriers that I think that has been addressed is that sharing of information, and sometimes there is quite a bit of an administrative work that needs to be done to get the information back and forth so all parties understand where the person is at in their medical necessity need, where they're at with their discharge planning. We, as you heard, have some MCOs that have access to EMR systems, some do not. It's dependent upon each of the facilities and the interactions with the MCOs. We do have ongoing interactions with our partners to help look at ways that we can improve the system, looking at ways to reduce that administrative burden, and making sure that our members are getting the right level of care. We all use some type of electronic portal to receive information, which does help with that administrative component of inpatient reviews. One of the other barriers that has been addressed by both of our partners today have been those really complex cases that really prove to be challenging. We spend quite a few man hours trying to find and locate the right level of care. We do complex case staffings across systems with the state, and sometimes there just isn't availability or the right facility to transfer a person to. And a lot of these cases are very unique. They're not the norm, they're the exception. And they do take up a lot of time and resources trying to be creative and getting people moved out of the hospitals and into a different setting that's more appropriate. That was what we had prepared to present to the committee. I will ask if you have any questions or if any of the other MCOs want to add anything else.
Committee, do you have any questions for Dr. Berg or for any of the other MCOs? Representative Landwehr.
And I don't know that this is a discussion that we can get into at this time, Sandra, and I appreciate the information you've provided. But it sounds like to me in my one-on-one visits that I've had with different hospitals in my area as well as around the state, and I think if you were listening to some of the testimony earlier, I think that we've got some glitches and problems. And I don't say that it's all an MCO issue. I think we see some of those same glitches happen on the private insurance sector. But I would like to have an opportunity at some point, maybe for some of us to sit down and look and, really understand how prevalent were some of the issues you heard today. And how do we avoid those in the future? Because I don't think that's good for either side, because somewhere along the line, someone's paying that price. And unfortunately, many times it ends up being the taxpayers. So that would just be a request for the future. Thank you.
I agree, Representative Landwehr, and I would welcome that conversation. I think there are lots of opportunities. Made mention that partial hospital and intensive outpatient treatment is not always available. And that's not a Medicaid benefit, but it is something that we need to look at again and how we can connect the dots between the levels of care and the continuity of care within our system.
Thank you.
Not seeing any further questions. Thank you again, Sandra, for your testimony. Committee, I would like to draw your attention to written only from Rennie Schuler-McKinney, Director of the Clinical Service, Behavioral Health, Advent Health, Shawnee Mission. Our next topic is MCO presentations. These are, oops, sorry. Oh, I apologize. Sandra, are you still available to answer a question? I apologize.
I am.
Okay, thank you. Representative Rees had a question.
Thank you, Mr. Chair. Sandra, how possible is it for the MCOs to get together, the three MCOs, and have the same process for prior authorizations?
We have worked on that together as we prepared this testimony, and we continue to work collaboratively. And if there are specific things that we can identify that we can pull together even more, then we would be more than willing to do that. And I would invite the other MCOs. I'm a little uncomfortable speaking for them as well, but I don't see that as an issue. I think we work together quite well. Now, there are some proprietary things that we have to be considerate of, but yes.
I just figured since they sent you to speak for them that you
they have to be careful
for the hospitals. Yeah, because one of the things is that pre-certification, needs to, there seems to be a 2-3 day delay, and that's something that just needs to, gosh, what needs to happen for that to be done in a day?
Dr. Inchwat, would you like to answer that question, or would you like me to take it?
I could answer partially, and then you can also address. I think part of our issue is sometimes access to EMR, because that delays the communication with the hospital and with the staff. That would definitely solve the issue. Again, communication is the key with the hospital, with the discharge planners and our team. And one of the things that stood out when we collaborated on this statement, and again, it was mentioned earlier today, is the lack of the beds in a long-term facilities, whether it's because they're full or staffing issue. So the hospitals keep the patients because of lack of that ability to discharge patient to another facility. So we've addressed, or we talked about this internally, and I think it's important that we maybe have a like a collaboration on what would be other solutions for some of our long-term care for some of these difficult and challenging patients.
And I think the hospitals understand that, that's a whole different issue, discharge planning with patients who have multiple, issues, and housing being a huge that. I was referring more to the pre-certification process where, that could take longer, and you're saying that that has more to do with access to the medical records. Does that mean that you're waiting on a fax from the hospital with medical records, or you have a different kind of access to medical records?
That is my understanding from our team, is that we authorize the first 7 days, but after the 7 days, we ask for medical records for the concurrent review. And we do this after we get the approval. We approve 3 or 4 days, depending obviously on the information. So really, it's the delay in getting that information.
So your certification process sounds a bit streamlined already because you're pre-certifying 7 days ahead of time.
Yes.
Okay. Okay, thank you very much.
Dr. Warrens?
Yeah, this is Will Warrens, Behavioral Health Medical Director for Sunflower. And I think your question is very pertinent. Okay, sorry, this is Will Warrens, Behavioral Health Medical Director for Sunflower. And I think your question is very pertinent. I think that when Ms. Chadwick was talking, I think we have had a great working relationship with Via Christi. We do with KU as well. And one of the wins that we did internally at Sunflower was to make sure that there was no retro reviews, with the exception of the first review. So if someone's admitted to the hospital, we wouldn't know they're admitted to the hospital. So that review does happen after the calendar day of admission. But after that point, we don't do any reviews after the calendar day. How do I want to say this? After today, we make sure all our reviews are live. Not only are they live, but we also are sensitive to the fact of what time we're going to give the feedback to the facility. So a review that I'm going to deliver back to a facility at 4 p.m. Might even be different than one that I would be giving to them at 8 or 9 a.m. Just knowing that, if I'm going to issue a denial at 4 p.m., I mean, that doesn't sound like it's going to be a very safe discharge or very planful discharge. So that is a quality metric that we were able to successfully resolve within Sunflower, and is really important to providers, I think.
Representative Concanon?
Thank you, Mr. Chair. I'm glad Representative Ruiz had a question because I was kind of pondering this. It sounds like a big part of what the issue is that we're talking about today is focused on the medical necessity. And so I had made a note here that the MCOs use a nationally accepted tool that has, I kind of paraphrased, but has criteria that the patient must meet. And I'm wondering if all the MCOs use the same tool, and if that tool is just decided on, or is it in the contract with the hospital, or how's that decision made? Agreed upon, or is it agreed upon?
Yes, excellent question. I don't know if I can answer all. Oh, sorry, Will Warrens, Behavioral Health Medical Director for Sunflower. So I don't know if I can answer all aspects of your question because there are different products out there for medical necessity tools. They're all validated and they all, whatever tool that an MCO picks, we do have to get tested regularly on that tool to show that we are using it correctly and that we're accurate. But as far as I know, I think there is some choice in which tool is utilized. But I want to emphasize the fact that when we've done a review, the first step is to use that tool, and then it's going to be in the hands of a licensed clinician in Kansas, and that person's going to have to look beyond that tool. If it's an approval and it matches what we're getting in the medical record, then that pretty much goes to a straight approval, and then we just approve and move on. But if the tool says that it's not meeting medical necessity, we don't stop there. Usually it means that the utilization manager then reaches out to the facility for more information. Is there something in the medical record that we're missing? And that happens very frequently. And then if it still feels like it's not meeting, then it'll come to me, and then I'll look it over. And I'm an active provider in Kansas, medical director for Kids TLC in Olathe, and actually treating patients directly, along with the child and adolescent psychiatry fellows at the KU. So I'm kind of thinking from a provider standpoint, it's like, what's going on here? And if I can't make sense of it and I issue a denial, the provider is encouraged to arrange a peer-to-peer. And I would say the majority of our peer-to-peers end in approvals, because then I can actually talk to the doctor and find out information that's not in the medical record, but is still very pertinent. For an example, some of these members that they're having a difficult time placing, when I finally talk to the doctor, the unit is doing a lot more work than what the medical record may. Not all the time. Sometimes the medical record is just full of medical necessity criteria and it's a slam dunk. But sometimes the medical record may not contain all the work that the unit is actually doing with that member. And so I think that's why a lot of the peer-to-peers end in approvals. So it's a multi-step process, and only after that peer-to-peer conversation, then being a denial, would we be talking about a patient that's now in a non-approved status at the hospital.
Thank you. Thank you, Mr. Chair.
Seeing no further questions, thank you, Dr. Warrens. Committee, that does conclude our presentation on discussion on hospital admission process. And again, I would like to turn your attention to the presentations by the MCO, written only. David Livingston, CEO of Aetna, Michael Stevens, President and CEO of Sunflower, and Kevin Sparks for the Health Plan, CEO of United Healthcare. Next up on our agenda is to approve the April 22nd, 2021 minutes. Has everybody had an opportunity to review those minutes? And do we have a motion?
Mr. Chairman, I move we approve.
Okay. We have a motion on the floor by Representative Concanon and a second by Representative Ballard to approve the minutes for April 22nd, 2021. Any discussion on this motion before we take it to a vote? Seeing none, all those in favor say aye. All those opposed, no. That motion is carried. Minutes have been approved. And committee, we are actually going to adjourn. But before we adjourn, one last reminder. If you're not going to be here tomorrow, please see Sky and get your voucher taken care of. Otherwise, you were up here for just exercise and nothing else. So. Pleasure of your company. And with that, committee, we are adjourned. We will see you tomorrow at 9 o'clock sharp.